So here we have our patient who's allowing me to do a full facial rejuvenation, which we call comprehensive. And I call it the aura lift is my face and neck lift, but when I do everything I call it a comprehensive, which means we can hit the lateral structures of the face and neck and the more centralized structures of the brow, upper, lower eyelids, lip, and she has a good nose, so don't need to touch that. I typically start with the more sensitive parts of the face in terms of markings, which would be the lip. That's the most important for me. So we look at the lip over here from the front and from the side, and the one thing you notice from the side is that she does have prominent alveolus and prominent upper teeth, but she also again has prominent chin which supports it well. So we're not afraid to do a lip lift versus somebody who has really prominent upper teeth and no support from the chin. Then you have to be worried about turning them into a rabbit or giving them incompetent mouth closure, so an incompetent upper lip. Here when we're making the markings, you want to start with a thin marking pen. You go into the crease of between the nose and the lip, and you just want to mark right along that, leaving no ledge. You follow this up to the peak, which is occurring over here at the divergence of the medial crural foot plate as it goes into the nose and the fatty fibrous part of the sill as it comes up and meets it. And that usually corresponds to the philtral column, although it doesn't always. So here we've marked up to the peak. We're drawing line 1. We want to find the peak on this side. So you can always just play with the nose and the lip and push them together, and you'll see that the peak exists over here. If somebody has a really deviated caudal septum, it's hard to see one side, so you have to kind of come around the caudal septum and then flex it and find where that peak exists. So we mark that peak over here. Here's our vertical marking for it, and then coming across the sill with no ledge, going into the crease and ending wherever the crease ends. On alarplasty and lip lifts, you do not want to go past that natural crease. You're going to form pores and scars that cannot be fixed. Does not matter what kind of alarplasty, does not matter what kind of lip lift. You do not want to go past that. Here we go, we have our vertical line markings that we're doing for the peak over here. And then if you play with the columella, you can find the dip right over there. And you come down. If you're ever doing a rhinoplasty at the same time, you do not use the same incision. It effaces the nasolabial angle. You want to just make a separate incision over there, and it's safe to do as long as you're not doing too many nasal base suspension sutures, which would cut off the blood supply if you did to this lower part, this lower flap on the columella. So now that we've drawn the upper limb markings, you can go ahead and draw the diagonal line, which is throwing your marker into the internal angle of the sill, right over there, internal angle of the sill, right over there. And then you want to follow out these relaxed skin tension lines as they go to the vermilion. And if you want to find the angle, you just look at the pores. They form an angle around the mouth, which is round. So centrally it goes vertical, and laterally it expands outwards in the mouth, which is round. And you can see here is your nasolabial fold, just like that. And it's progressively getting more vertical as you get to the philtral column, progressively getting more radial and outwards as you get to the nasolabial fold. So those are different ways that you can find it or figure out the angles if you're not good at looking at the pores. But here you can see that the pores do go out radially as well because they've grown three-dimensionally around the prominence of the mouth. Now what you notice, as I've shown in the other videos, is that between the two diagonal lines you have the subnasal lip, which is better suspended and everted, and then you have the subfacial lip, which is suspended from the face. It becomes more ptotic with age, is harder to put filler in, and typically needs to be treated with corner lifting because a subnasal lip lift only lifts between these two lines and does not affect much lateral to those two lines. Next thing we're looking at is the height of excision. If you open your mouth a touch, you'll see she has about 0.5 millimeter or 0 when you fully relax. She has 0 incisive display, which means the wet-dry border is at the level of the teeth. If you go up, it's plus. If you go down, it's negative. So she can take easily, in my mind, up to 7 millimeters. Her line of declaration is down over here. Smile big. You can see there's a crease that forms right over here. Relax. That's because the lip is straining, and everything above that could be considered excess. However, if you look at her and we look at this, that becomes almost an 8 millimeter excision. It's just over where I'd want to be. An 8 millimeter excision would be a little exaggerated on her because if you look at the height of the vermilion here, it's already tall, and laterally she's completely deficient. Subnasal lip lifts tend to lift everything centrally, nothing laterally. And if you were to do that full well, that's about 7.5 to 8 millimeters of the lip lift, you're going to end up getting too much central show, too much central exaggeration, and it's going to look imbalanced. So over here, we're going to measure out 7 millimeters. You can see it's going to be just above that line. It's going to be 7 millimeters, which is perfect for her. There we go. So we're going to mark just above that line is 7 millimeters. We're going to get to this one right over here, 7 millimeters. And this one right over here is 7 millimeters. We have our central 3 markings now, and then we're going to skip to look at what the residual is. She has a little bit of a blunted appearance over here. And we're going to draw the points of the P, the C, the I, and we have the D. You can see that her dip between these 2 points is not adequate, which means we might have to pick up the P's more than the central in order to get more of a Cupid's bow trough. So we look at the residual here is about 14, 15 millimeters, and we're going to probably want a 1 millimeter discrepancy. So here is 15 millimeters right there. That's 15 millimeters right over there. And then in the middle, we're probably going to take a little bit less. So we're going to stay on the upper part of that dot, which takes us to 6.5 millimeters centrally. So here we're going to stay on the upper part of this dot, 6.5 millimeters centrally, going to the 7 millimeters laterally on each side. And you can correct for asymmetries at the same time. When we're looking at asymmetries, we have to look at asymmetries in the nasal base as well, because a tilted nose can affect the symmetry of the lip as much as lip height discrepancies can affect it. So we had 15 millimeters over here, and over here, which parallels the 2 millimeter dip in the columella, so it should parallel the dip in the columella centrally. However, if you just step back and look at the lip, you'll see that the 2 millimeter dip from here to here. We want to continue that 2 millimeter dip from there to there, so you get a nice triangular peak and drop, and it's fairly symmetric from one side to the other. So 15 millimeters, if we add 2 millimeters, we get to 17. We want to mark our 17 for the eye line right over there. 17 millimeters on the eye line right over there. And then we're going to go up 2 millimeters again. We get to 19 millimeters for the D line. And that's right over here. And you can see this side of the lip drops off. So there's going to be a big one, which means we get another teaching point here. So you can see that's going to be way too much of a drop off to come all the way around here and to get this diagonal line to 19 millimeters. It's going to be way too much of a drop off. So what I can do rather than do this is excise more from the corner lift here to make the diagonal appropriate rather than taking from the excision height up at the subnasal. And the way you determine if you should do this or not is this was 15, 16, 17, 18, 19. So we're going to draw the intermediate line. So we're going to go back to 15 we drew. 16 is between the P and the I, between the P and the I. 17 we drew for the I. Then we go to 18 between the I and the D. Between the I and the D, between the I and the D. And then now you can see where the line really wants to be. However, I'm going to take 1 millimeter less from the diagonal line, which is going to put me over here, which makes my subnasal lip lift a lot more comfortable for me because I don't need to recruit all that skin from this area over here. So I'm going to draw and connect the dots, taking 1 millimeter less over there. Draw a vertical down from the apex to your diagonal. Over here, connect the dots. And again, draw a vertical down from the apex to your diagonal and have a nice smooth transition there. You don't want to have any sharp movements. Now we're going to draw our intermediate line, which is going to be our advancement for the intermediate. Perfect. Now to find the height of the corner lift, you draw a horizontal plane, which is where your lip is going to end up. That's where the lip's going to be sitting at the base of the nose. And you can see she has a tilt to it, so it is going to straighten her a bit when we do it. Our last line that we marked was 19 millimeters for the diagonal, so the outer line should be the same height as the diagonal line. The outer line is from the horizontal plane down right over there, and you can see that's where the height of the corner lip wants to be. And we'll draw that in a second. And again, on this side, we're going to go from the horizontal. So you go from the apex down to the horizontal, drop it down, and that gives you your diagonal, sorry, your outer line right over there. That's going to be the height of our corner lift. I'm going to turn you that way just a touch. You can see here, there's a vermilion roll, and then it drops off a little early on this side. So she's more deficient on this side. So I'm going to start my corner lift medial to the diagonal line, right where it starts to drop off. And that allows me to recruit an extra millimeter from this lower line. Here I come right around where the excess is, and I'm going to pull up on the diagonal line and then draw a straight line through where the height of that corner lift is supposed to be. Right over there. So we have our now 19 millimeters at the diagonal, which ends up at from the line 2 to the new line 3. You can see it's at the top of it. And then we follow down, and you see that the height of the corner lift is going to continue. So when we're looking at the ultimate design of the lip, it's the same height all the way across, going across this horizontal plane, which is going to be the new plane at the nose. So if you come over to this side just a little bit, this side doesn't need much of a corner lift at all. You can see we're just going to follow right around the corner over here where the excess is, come around the inflection, pull up on the diagonal line, and then draw a straight line through to connect the dots. So that's our corner lift over here. You can see here we did 7 millimeters, 6.5 millimeters. This is almost 8 millimeters, and then 9 millimeters on the side over here, whereas this side becomes against 7.5 millimeters. So there's about a 1.5 millimeter discrepancy between the right and the left side where this side falls off. So if you were to look at the lateral part, let's say we look at 9 millimeters, so that's 9 millimeters right here. If you look at that line to that line, so we're taking 9 millimeters there, we're taking 1 millimeter there. So this side from the diagonal is getting a 10 millimeter excision to leave her with 19 millimeters. So she actually has 29 millimeters over there, versus this side, we're doing just over a 7 millimeter excision with no recruitment on the bottom, so that's just over 7, so 7.5. And we're doing no recruitment from there. So this side of the lip is about 3 millimeters shorter than that side of the lip. So that's going to help get the symmetry over there. And I tell patients you're never going to get full symmetry. I'm just going to make some things more symmetric. And that's how we do that. So we go to the next part here, which is going to be the upper blepharoplasty. Upper blepharoplasty, you have to look at everything around the eye. You have to look at ptosis, you have to look at brow position, you have to look at the amount of fat in the infrabrow and hollowing in the sulcus. You have to look for lacrimal gland ptosis, and you have to look at for tarsal platform, and what parallels tarsal platform is the infrabrow height. And you want the infrabrow height to be even all the way across as well. So we have to look at all these things. Close your eyes, please. Now we're looking to see where we want to place the crease. If you look at the crease that's forming on her, it's about 14 millimeters, which is too high. The range at which a supratarsal crease should be placed is anywhere from 6 to 12 millimeters. That is pretty standard, I'd say, as far as making things standard in the face. You have to look for where the crease wants to be on her. If you play with the brow, you'll find that she has this lateral crease right over here. And when somebody's really tall like this, you say, okay, what's the tallest I'm willing to go? And that's 12 millimeters, which is exactly where she's ending up, is 12 millimeters. And 12 millimeters, you're marking that centrally towards the mid-pupillary line. And if you look and stretch her out, you'll see that she actually has 12 millimeters there. So we put our caliper to 12. And the reason to mark your caliper is to make sure they have symmetric tarsal platform on each side. So you mark it to 12 and you stretch it, and you see she's at 12 millimeters. So that's 12 millimeters there. And then she has a crease here that, again, is 2 millimeters above, just like on the other side. And we're going to go 2 millimeters below. So she's pretty symmetric. So that's our 12 millimeter crease right over there, which falls into a minor crease that she has. But the way that you find that is really by following this outwards here. That was the easy way for me to find it. And you can see where the supratarsal crease affects this outer fold over here. So you keep playing with the eye and you can find where the crease is supposed to be. You want to treat the brow and the eye completely separately, independent subunits. Open your eyes. Many people treat them as one subunit, but I don't think that's correct. Here you can follow into this crease she has right over there and connect the dots. Close your eyes. Now you can see it right over there. Open your eyes. And you want to make sure you don't efface the epicanthal fold. Now, medial rhytids in the eye, close your eyes, are a point of contention for some people. They get upset that they still have medial rhytids after doing an upper blepharoplasty, and it's because most medial rhytids actually come from brow ptosis. Brow ptosis occurs medially and inferiorly here, and you can see what that does. It adds to these rhytids here, and it creates a rhytid that comes straight across the inferior part of the glabella and then comes in a diagonal fashion up the side of the eye. So if you see diagonal rhytids here, that's from medial brow ptosis, and that's how you fix it, is by getting the brows outwards just a little bit like that. That fixes all the medial rhytids. And then you can say, open your eyes, and you can see they're all gone. Whereas you go here, you have all these diagonal rhytids which occur right over here on each side. So they look like these little wings because the brow is sitting down on an eye that's curved like this, and it forms a wing when you do that. So you get these little ala that come like that. So now we're going to finish the marking over here. Look up a little higher now. There you go. So you just want to come right around the hooding over there. Close your eyes. And you want to follow the contour shape change, which occurs right where the eye folds onto itself. So that is where it's supposed to be. You have a little scar. Do you have a skin graft over here?
Mm-mm.
Oh, yeah, you got a little scar over there. And you want to follow that contour. And this is how you maximize or do appropriate excision, is by following those contours rather than saying I need to leave 2 centimeters behind, rather than measuring it out. You really just look at where the eye folds onto itself, and that's where the excess is. You don't want to hollow somebody out by taking more. You don't want to cause poor eye closure. Now the brow is going to give us this regardless, so we just double check, open your eyes. We say, okay, perfect, we got everything. Now I'm going to come to the other side. Okay, close your eyes. So I cheated, I don't have to look for the crease on this side because I marked it with 12 millimeters, but you can see that that's where the skin falls onto itself. And you want to just do little dots. If you do little dots into a crease, the eye is very sebaceous, as we know by it creating milia. And any skin that is that sebaceous tends to be greasy at all times because it forms sebum. And if you just draw a little dot into a crease because of the sebum, the capillary action of the sebum is going to go ahead and take that marking pen and spread it automatically. So you don't need to really put that much ink in there. Open your eyes. And gentian violet, which is the ink that we use, spreads very easily. It's also antiseptic. So anything you touch with this marker kills the bacteria. Close your eyes. And we're going to come over here. You can see where that fold is. So this becomes a game of really being able to see the contour. If you're not somebody who can see the contours very well, then yes, you have to stick to measurements. If you're good at seeing these little contours, then this works out much better for you, and your revision rate drops dramatically because you end up excising the appropriate amount every time. Open your eyes. So we're going to follow into that crease right there. Close your eyes, and then you just connect the dots. Open your eyes. So you can drop it down and see where the crease forms. It's all the way over there. So I don't believe that it's correct, close your eyes, that people do inflections every time to get that medial skin. I think they're misdiagnosing brow ptosis for eyelid excess. Open your eyes. And always make sure you go cleanly in there so you don't efface the epicanthal fold. Close your eyes. You want a sharp apex. If you have a sharp apex, you're less likely to get hypertrophic changes afterwards. So there you go. You can see that's exactly where her fold is. Now, to treat her upper eyelid appropriately, we also have to put a little bit of fat into here where there's deflation of the infrabrow. When you're filling fat down into here, realize you're not filling fat that was lost in the preaponeurotic space or into the globe fat. It's actually just the brow periorbita or brow fat. And the brow fat, you have to think about it three-dimensionally because it wraps around the orbital rim. So if this is your orbital rim, the brow fat comes all the way around it like this. And so part of what you're filling when you go in is going to be in front of the brow fat on bottom and then into the sulcus. However, this is above the preaponeurotic plane, which goes like this. So if this is your orbital rim, we're going to be filling it all the way around, and that's what you have to look at over there. Lower lids we'll take a look at. Open your eyes, look upwards. She has a little bit of wrinkling here, and you have to decide, is this skin excess or is it skin quality issue? If it's a skin quality issue, you can do a chemical peel, look up. If it's skin excess, you can excise it. She has the tiniest bit of both. If we wanted to really get the lower eyelid substantially improved, we do a skin excision on her. Skin excisions, you should not do skin pinches. Skin pinches go vertical, and if you see her eye, every time she moves, you can see all these rhytids that come right over here. The eye ages medially. You want to fix it going laterally, like this. If you do a skin pinch, you go vertically, and you end up pulling down on the eye inadvertently. So if we're going to do any skin excision, we're going to mark a subciliary marking, which is right under the lashes. The key here is to stay as close to the lashes as possible without damaging the lash follicles. And then you follow it outwards, and you'll see a crease that comes down before the canthus, and you go obliquely downwards like that. And we can excise skin, which is going to go as a skin flap. You'll see once you release, it'll come out in a superolateral direction. When I do that, I like to put a little canthal support, so I either do a retinacular suspension laterally or a canthopexy stitch. Canthopexy stitches will never be as strong as your natural canthus, so you do have to be careful and cautious, because just doing a canthopexy can actually round off your eye if you disinsert the canthus. So I'm just going to mark this. I'll probably do like a little bit of a skin excision there. If most of my blepharoplasties are transconjunctival, the problem, unfortunately, with making surgical videos is people see one thing and they assume you do that for every case. However, I rarely do skin excision. It's uncommon. I do mostly chemical peel, TCA 35%, and I do a lot of fat repositioning. However, fat repositioning for her is not going to give her anything more than just reducing this lateral fat pad, which you're barely going to see anyways once I lift her and lift the brow. So I don't think that's going to be necessary. So if I do anything, it's just going to be a little bit of a skin excision there. So now we go to the next part, which is going to be the brow lift. Brow lifts are always pulled in the wrong direction. If you ever pull somebody in the direction of the frontalis, you have pulled them in the direction of the mimetics of surprise. So you don't want to pull someone this way. That is not the vector to go, and it's also too far, what most people do. The reason brow lifts fail is, the most common reason is because people pull in the wrong vector. If you look at the medial brow, the brow and the scalp came down forward together, and you want to just take it back to where it was. And if you do a distension of the scalp this direction, you'll see that the most minimal movement diagonally fixes all the medial brow. The lateral brow gets more movement as it goes up and back in this direction. So we're following everything along the superior temporal line. The brow did not come down by itself. There's no skin excess in the forehead that's formed. It's just getting crowded because the scalp came forward. So you have to uncrowd it by getting rid of the slack and the redundancy and the pressure on the eye, and that takes all the stress off of the eye. When you're like this, there's a lot of stress on the eye, and the eye is always struggling to remain open. When you're like this, the eye can relax, the brow relaxes, and the brow shape changes. As you age, the strength of the frontalis is right here. If this is your conjoint tendon, 2 finger breadths medial to that is the strength of your entire frontalis. That's where it goes up. Your depressors pull it down. There's no lateral support. There's no muscle here. So the lateral comes down. Medial has procerus and corrugators, which corrugate and bring you down medially. So your eye shape changes as a dip there, and a peak here. Now, if you want to fix someone's eye shape, you don't need to know much about how to design it. You just take all the redundancy off the scalp, and when you do that, you see it starts to straighten out because now the frontalis doesn't need to work so much anymore. So it straightens out automatically. So you don't need to know anything about those articles that describe the position of the arc relative to the limbus or the line from the nose to the canthus. You don't need to know anything about that. All you need to know is take it off, take the stress off, put it back to where it was, and everything goes back to normal. So to do our brow lift, I want to draw the superior temporal line, which if you can see the temporal hairs here go vertically. We're going to draw the superior temporal line following down over there, and that is the bony junction between the frontal and the temporal bone, parietal and temporal bone. And it's where the temporalis muscle inserts and where the conjoint tendon is. So all those things coincide. It's also from where your frontalis muscle goes to temporoparietal fascia, and then posterior to here becomes your galea aponeurotica. So that is all your SMAS plane is your frontalis, temporoparietal fascia, galea aponeurotica, occipitalis, that is the same as your SMAS. So to see where we want to put our incision, we don't need to do the classic 4 points unless someone has a recessed apex of hair. What we want to do is put our fingers right across the brow and see where the pull wants to be. On her, it's very obvious that it wants to be here. It doesn't want to be here laterally, it doesn't want to be here medially, it wants to be right here, and that's what really gets rid of all the slack. And I'm doing this by partially sensation, so I have to feel where it wants to go. So I do is I do this, and I come back along the superior temporal line, stop right there, and 2 finger breadths apart, or 2.5 centimeters, which is an inch, I draw my line. And it's a curvilinear line because we're going to go against the 3 vectors of aging, which is 1, 2, 3 vectors of aging on the brow. And those vectors are determined by gravity and muscle function. So muscle function is pulling you medially, muscle function is pulling you laterally and down. So that's that, and then gravity pulls everything down. So gravity and muscle function determine the vectors of aging, which helps you determine the vectors of lifting, which is going to be 1, 2, 3, like that. So that's our goal, is to get everything lifted, get rid of all the slack all the way across evenly, and then you end up with a balanced brow that looks more pleasant. A brow lift doesn't need to lift the brow so high. It has to get rid of all the crowding on the brow. So people mistake that. You don't have to go directly at the brow to try to lift it. All you have to do is get rid of the crowding which has occurred on the brow over time by taking the scalp back, and the brow can relax into its proper position with appropriate function. So here we draw our superior temporal line. And again, I'm going to put my finger an inch apart, bring it back like this. I kind of know where it wants to go. It already wants to go here. It's obvious because that, with my finger, gets rid of all the redundancy. Here, she still has redundancy over there. Here, she still has redundancy over here. Here, she has no redundancy. Everything lifts up together. So I'm going to put my fingers there, move it back into the hairline. This one is slightly more medial than the other side by a couple millimeters, not much. Curvilinear, because I'm going to pull against this direction, that like a parachute. And that's that. So that's going to be our brow lift. You can mark your nerve, which your neurovascular bundle, supratrochlear, supraorbital, comes out at the medial limbus. You can mark it up, or you can just put your finger there and you can feel it. We don't use an endoscope, it's an endoscopic approach. Now, before we go to the facelift portion, we're going to do the marking. So if you turn your face all the way to the side, please. Can you do a big smile? There we go. So you see a depression over here, and this is what some people would call witch's chin. A witch's chin deformity, relax, occurs when the chin dips downwards in an exaggerated fashion, which either occurs because of disinsertion of the chin iatrogenically, overfilling of the chin iatrogenically, or naturally because there is poor muscle support here, which is the junction, in the submental crease is the junction of the mentalis to the platysma. The mentalis and platysma have intertwining fibers. So they are here considered one muscle. If you've seen them a million times, there's horizontal fibers that go across there, or diagonal or oblique fibers that go across there. It's different on different people. And the depressors are out here. The depressor anguli oris, labii inferioris is over here, and then you have your mentalis, which comes across, and it intertwines with your platysma. So here they're the one and the same muscle. They intertwine and they function together, which is why platysma and digastric, which are also overlapping each other, always affect the smile. It's not 10% of the time, it's always. However, if these muscles don't have good support here, which they don't on her, what's going to happen is instead of flexing evenly across that space, they're going to indent as they flex. Smile big. You can see what happens here is the platysma and the digastric strain, the chin strains, and they indent. So all you need to do is provide support there, relax, and it'll start flexing better. Support here can be obtained by fat grafting or by other fascial grafting. Fat grafting is the easiest, and you can get into the pregial sulcus as well. So we're going to draw the fat graft. The other thing that you have to do is get the hyoid, which is down over here, into a position that's above or at the level of the chin. So we have to suspend the hyoid upwards into a more vertical plane. If you can get the hyoid and all the neck contents and jawline above this vertically, then the witch's chin ceases, and fill this with a little bit of fat, the witch's chin ceases to exist because our vector of the jaw is now this way. Versus right now, the jaw to the neck goes this way, and when they smile, you get this exaggerated little U shape that's over there. So you don't need other complex types of things. Here you can follow this line over here down into the witch's chin where it's happening, and then you can see this color change over here, which is your prejowl sulcus. Smile big. So you can see over there this line that's forming, so we'll have to fat graft slightly into that, going into this area, and then you can see this depression, which we call the prejowl sulcus, where she's missing fat. Relax. And if you don't see it there, you can pull up on the face and you see here is your indentation. So you have to do fat grafting into this diamond right over here, slightly behind the submental crease which is forming, and that will fix the witch's chin. Turn over this way. Volumetrically on the rest of the face, she's fine. She doesn't need any fat grafting except for the tiniest bit into this lid sulcus, which I'm going to put from a dot over here, a dot over there. Temples are fine. You always want a little bit of a temporal depression coming out to a cheek. And that's all she needs for that. Okay, so no other fat grafting is needed. I'm going to turn you over this way. This side is not as prominent. Smile big. You can see that grafting kind of falls into there. Relax. And repositioning this is going to cause less of a strain. Right now the muscle is straining because it can flex from here to here in a shorter distance. We have to lengthen the distance, pull up the hyoid, get it above that, and it'll stop doing that. Pulling this up over here, you see she has a very minor depression on this side. Nothing like the other side, but it does extend down into that area. So you really do have to three-dimensionally fat graft. People are not used to fat grafting down there, but once you graft, it comes back on the face and you'll realize why. Okay, so we're going to mark the facelift now. So we're just going to mark around the temporal tuft. There's no good reason to do a hairline incision. There's plenty of reasons. There's no good reason. The natural anatomic subunit of the temporal tuft has to stay intact. It's your sideburn. If you ever get rid of this and lift it up over here, you've elevated and lengthened the level of the cheek. So when it's here, the cheek goes from here and it ends right there at the lateral part of the zygomatic arch. If you ever lift up your sideburn, your cheek ends all the way back here and you look like you have a big, long, flat face on the side. So it never looks good. How to determine how far to go over here? You lift up the brow to where it wants to be, you lift up the face, and you see that all the rhytids are all accounted for and redistributed. So that's as far as you need to go on that. Over here, we're going to come down at the prehelical crease, and you can choose, do I want to do retrotragal or pretragal? Pretragal is always more anatomically correct because the ear and the face are two separate subunits. You don't want to efface that border. However, some people don't have good enough skin to make an incision there that's going to heal perfectly, like people with acne, so you don't want to do that on them. Her skin heals fine. I'm not worried about it. And I'm looking at the character of the ear. She can go either way. So I can do a pretragal incision on her, which is going to go into this crease right over there, and then follows into that apex, just like that. Or I can do retrotragal if I want. I prefer pretragal on most people. If I do one side pretragal, I could do the other side retro. It doesn't matter. The face is not symmetric. They're not supposed to be the same. Over here, we just draw a line into the postauricular sulcus, directly into the sulcus. When you lift the ear, you have to realize that you pull the sulcus skin out. So make sure that at rest it's in the sulcus. And then as you get back here, you'll see that there's an area on the mastoid which is round, turns flat. That's where you traverse. So that's your transverse posterior limb. And then you can follow the hairline down. If this is too narrow, because the hairline ends here, you have to go into the hair and down. But this is nice and broad. You have a couple centimeters. It's going to get a good enough blood supply. You don't need to go much farther than this. The farther down you go, the worse the blood supply gets to the superior portion. Around the occipital hairline you go, the more, again, you lose blood supply over there. Now over here, we're going to draw Patenge's line, number 1, which is between the hairline and the brow, connecting it to the base of the earlobe. That gives us a parallel to draw for the canthal line to the gonial angle, or the lateral border of the masseter, which is our deep plane entry point right over there. If you look at the masseter and she clenches, clench your teeth, There you go. You can see this bulge, relax, ends right over here. The pores change on the skin. Where the pores change, this is your masseter, this is the body of your masseter as it goes deep into the buccal space. Your platysma also inserts onto the face at this point at what we call the mandibular ligament. You can see this externally. If you were to push inside, you could also feel that you're at the bite line of the teeth. So it's the same exact junction as all those three things. Superiorly here, if you follow down, you'll see again those pores, the color change. You see all this color change. You see these pores here in the middle of the face. That's the buccal line. Above you have your zygomatic line. So this is your zygomatic line, which is your inferior zygomatic complex. You can see it externally. Over here, there's a depression under the zygomatic line. We call that McGregor's patch, or zygomatico-cutaneous ligaments, which occur right over there. And then at the inferior border of that, from the anterior part of your parotid, comes your parotid duct into your buccal fat pad. So you can see all these externally. Now, instead of using this as our deep plate entry point and lifting up over here and having this be skin only, I want to extend an island of SMAS to keep it composite and have this go up as a puzzle piece instead. And the way you design that is sailboat is about 2.5 centimeters at about 70 degrees, paralleling the incision. This is 2 centimeters, which is fine. I can always trim. And then you can see her face is going to want to go much more vertical. So she's going to be more of an 80-degree lift than other people. Here you can see a little tail of parotid over there, very, very small amount, not much to do. If you look from the front, she's got a very broad larynx as it comes around. So even if I pull, she's broad there and she's low, which means I do need to do some volume reduction around here to decrease the resistance of me lifting the hyoid and the larynx up. When I do this right now, I feel resistance. So when I go in there, I'm going to do some reduction, always reduce laterally before centrally. Put your chin up, please. Now you can see where we're going to mark the submental crease. She has a crease down over here, which is, I'll lean her back so you can see, which is the tempting place to go if you want to keep your witch's chin and not fix it. So this is where most people would go, is right over here into that crease. Smile big, and you can see why. That's where she flexes. However, the incision should follow the internal mandibular line as it comes all the way across here, and you see that the line is actually anterior to that. And if you follow the internal mandibular line, that is how you determine where your submental incision goes more appropriately. And that will allow you to access all of the muscle and tuck all of it back. Versus if you went here, this portion of the muscle would be unaddressed and you'd still have a portion of your witch's chin. Draw the midline, drop it down. There we go. Now we're going to mark the other side of the face. Here again, you can see we're going to draw our temporal tuft. You want to ignore the wispy little villus hairs, and we just go for the solid hairs. That's where the incision is going to hide the best. You don't want too sharp of an apex there. Come into the crease, right over that side. And again, you can go pretragal or retrotragal, dealer's choice. She can actually do either one because she has a diagonal crease that forms right here through the incisura. So you can go either way. But again, I prefer pretragal when I have the choice of the two because the anatomic subunits stay separate. So when I'm being super analytical about my photos, that always looks a little bit more natural to me, even though you can't tell. Falling up in the postauricular crease, and over here we're just going to come right across where it goes round to flat, and then down the hairline, not cutting into the hairline. And then here we have Petenge's line from right there to there, drawing it down, and then here you can see the lateral canthus going down to the gonial angle, which is also the lateral border of your masseter right over there. Here you can see how the color changes, and you can see it on her because she's got pigmentation. It makes it even better. But you see the pores here, and the pores don't exist here. That is your masseteric ligament. It is where the masseter goes deep into the buccal space under the parotid duct. It is also where the platysma comes and inserts onto the face. It is also, if you push, your bite line. Again here, your zygomatic line, that's your inferior zygomaticus muscle. And you can see that follows all the way back over there. And then over here, you can see is going to be that buccal space. So it's your parotid duct. Buccal fat pad's going to be soaking it over here on the anterior border of the masseter and forward. And below this is your zygomatico-cutaneous ligaments right over there. And here you can parallel the incision to make what we call the sailboat modification, which decreases the amount of skin dissection you have to do and makes an overall a little bit more of a contoured result out here instead of getting flattened. Not much of a parotid tail here. which is great. You don't have to put much back in, but you see how broad that larynx is. So this whole larynx is really broad. You can see it's broad and it's anterior. So we are going to try to bring it back a little tiny bit. She's so stiff it's not going to move much. We just have to make sure that we lift it slightly vertically and give her a tilt backwards. But that's going to be our limiting factor over there, because the more you try to bring this larynx back, the more limited you are on lifting up the face. Here we just like to analyze the face beforehand overall, going from top down. When we're looking at the eyes and the brows, you can see that there's a bit of asymmetry, and the asymmetry follows asymmetry of the brow. If you see, there's less of a tarsal platform on this side than that side, yet her eye opening, her eye aperture is identical, which means that the asymmetry is coming from the brow position, not from ptosis. This side is a little bit lower than that side. Now, for us, it doesn't make a big difference because I'm going to release maximally and reposition it. However, if you're really doing a brow symmetry procedure, you have to look at the brow position relative to the tarsal platform, ptosis, fat or infrabrow fat, and the hairline. And here you can see that the hairline does tilt that way. Frontalis, if you follow her pores, does tilt that way, and her brow tilts that way, which means she's a candidate for an endoscopic asymmetric lift to make her more symmetric. Whereas if somebody has a horizontal hairline, a horizontal frontalis, and a lower brow, if you do an asymmetric endoscopic lift, you will take their horizontal frontalis and make it asymmetric, and when they lift up their eyebrows, they'll get this wave form in there, which is not going to look very good. So it is important to look at all those things. Now coming down to the eyelids, you can see she's got this medial brow ptosis, which is what these diagonal rhytids are. That's going to get improved with our brow not going upwards, but going this way. And that's going to improve that. The lateral hooding is there as well. Lower eyelids just has some wrinkling. Again, this is something that you can see bunches up in the middle more because the medial canthus is where the orbicularis is anchored, and the muscles pull this way and pull the skin that way. So we age in an inferior-medial and then superior direction on the lower eyelid. If we remove skin, it's going to be up in that direction. This can be something that you chemical peel, or you do a skin excision. For purposes of the video today, we'll do a skin excision, which is rarely performed in this office. Getting down to the lip, you'll see she's got a little bit of flared nostril, nothing too bad at all. She has a horizontal nasal base, which is fantastic. She's slightly lower on this side than that side. So you'd expect the lip to be lower on this side than that side. However, it's not. This is the side that's deficient, which means she actually has a real lip asymmetry where this side is taller in the philtrum than this side. And we've accommodated for that with our procedure. And to the side, this is going to be the real money maker for her, is going to be getting rid of this indentation, which forms the witch's chin, and elevating this entire neck, which gives her a cervical mental distance of about 2 to 3 centimeters here. If you look from there, it's about 2.5 plus, and then here it's about 2 centimeters is her entire cervical mental distance. You'll see at the end of the case, her cervical mental distance will be closer to about 5 to 6 centimeters as we extend in towards the hyoid and suspend the hyoid up. Now the hyoid at this point is down here with some soft tissue in front of it, and she has a tilt that exaggerates the appearance of the witch's chin because the vector of the neck goes down. We're going to elevate the hyoid up here, and then the entire chin vector and everything is going to follow and parallel the mandible. So you want to have your hyoid to your chin parallel the mandible, and that way you don't have a hyoid that's lower and everything tucks back up into the submentum, and the tongue and everything goes back up into the floor of the mouth. So this is something we're going to lengthen, elevate upwards, and we're going to redefine this entire ramus that you don't see anymore. Her ears don't need much rejuvenation. It's always beneficial to look at the ear before proceeding to see if you have to fix anything over there. Here we've harvested fat. We use the 2.4 aspiration cannula from Tulip, and we put it on gravity drainage over here, rinse it a little bit, leave it for just a couple minutes. And we do Telfa sandwiches. Telfa sandwiches allows all the grease, water, and fluid to be absorbed. You can Telfa it once or twice. You want it to be relatively dry, and you want to backload it into a 20 cc syringe. I use a globe retractor that we use for the eye, and I have one in my fat tray, and it helps just backload these syringes pretty easily. It's always easier to backload into a 20 cc syringe than a 10 cc. You can also rinse on top of these. If you have the greasiest, oiliest fat ever, sure, you can use an ABD pad, but I like the Telfa sandwiches much more, and it is one of the less traumatic ways to process the fat or to rinse the fat and clean the fat. You want the oils out of it as much as possible. Oils and blood are slightly inflammatory and will prolong your recovery time. So you just drag it across until it dries up over the telfa, and then you can load it into the syringe. The biggest factor, other than traumatization or doing less trauma on the fat, is to inject the fat as quickly as possible back into the body. There are breast surgeons who have published on the fact that when they would do one side of the breast, fat grafting, then surgery, then skip to the other side, fat grafting, then surgery, the side that they did second would always be smaller because the fat wouldn't survive as much. So one of the keys is early re-injection into the body. Now, if you pull out of a 2.4 cannula, you don't need to do much in terms of actual processing. Everything is technically micro fat. These are very, very small granules of fat, which is fantastic for the face. You don't want big granules in the face. And the fat can survive 0% or 100%. On average in a population, maybe you'll find 60%. However, in the individual person, the chance of surviving is 0 to 100%. And you cannot assume that because of population 60% survives, that in your patient 60% will survive. It's inaccurate. So I inject exactly to what looks right and I stop there. Fat can grow in the future. So you have 10 cc's of fat. We're going to pass this into 1 cc syringes. I fat graft nearly every case I do. However, I only inject about a teaspoon or less. So most people I inject 1 to 2 milliliters just for little indents in the pregel sulcus. Some patients I inject in other areas. We're going to start by injecting from top down. I like to look at the temples. They look fine. You always want a little bit of a depression here as it goes to the cheek. You do not want a big depression behind the orbital rim. So if you do have a big depression there, you can fill it to pop it out. However, you have to look at the overall size of the head, height of the head. You never want to make a prominent head. So these temples are largely overfilled on most people. She doesn't need anything. As she lays down, she loses a little bit of volume there. When she stands up, she's fine. I'm going to come from a point here, which is going to be between the neurovascular bundle and the conjoint tendon. It's a nice loose plane over there. Make an 18 gauge, poke it just to get through the dermis. Don't go farther, you're going to start bleeding. Put it on the other side, leave it there. I'm going to use the SL20 cannula, which is a 20 gauge cannula. This is from Tulip. You come down, you're automatically in the periosteum. On the periosteum, you push forward, and now you're in the bag of the periorbita. The periorbita wraps around the orbital rim like this, three-dimensionally. So when you go down and you push like this, even though it looks like you're in the sulcus, all you're doing is pushing down in the periorbita and it's stretching like that from the brow. And then when you release, it retracts. So here we go. We're going to push down as low as we can. Small aliquots. You're trying to incorporate the fat into the surrounding fat. So we're doing 0.05 cc aliquots, starting from the inferior part just to get our lining. You always want to head towards the trochlea here, which is where most of the deflation occurs. Now you pull up onto the bone and you push that fat to disperse it so you don't have any lumps or bumps. You don't want little balls of aliquot. You want smooth fat grafting. Now you're going to come here into the direct infrabrow. We're going to go higher up. You're injecting behind the orbicularis, which is in your brow fat or your brow periorbital fat or periorbita. And we are injecting really small aliquots across, focusing more on the medial portions than the lateral on most people. Not everybody. Everybody's different. Then you want to pull up again and you see these lumps and bumps. That would be terrible. So you have to push it against the bone and you disperse it and it's gone. You want to wrap it up like this, push it up. Great. Just like that. Now it looks smooth and you can see from one side to the other, it's a much rounder convex appearance than the concave appearance that you have on this side. You never want to take someone from a 2 to a 10. So if somebody has a very hollow eye, don't go fill it all the way to perfection. You're going to alter them too much. So you need to kind of scale back what you're doing in super hollow people. Do not go for a full repair. Also, if you're going to fat graft somebody, you should ask them if it's okay to fat graft their lid sulcus or mention it and see what they say. Because they might say, oh, no, I love the hollow look. There are people who love the hollow look because it's a classic appearance of beauty in the 60s and 70s. And some people are that old. So you have to look over here. You see we're hollow over here, full over there. We're going to come down into the lid sulcus again, pushing down the tiniest little aliquots as I'm going. So you're just depositing them. You're not doing retrograde, you're not doing antegrade. You're pushing the tip all the way down to where you want it to be, and you're depositing the fat at the end of your tip. Remembering that this fat can grow, this fat can draw in water, the fat can hypertrophy with granulation in terms of just volume alone. The fat can grow with weight gain. It can change during menopause. All these things can actually increase or augment the amount of volume in there. So don't overcorrect because you read a research paper that said 60% survives. That 60% has nothing to do with this individual patient. What you need to read in that research study is what the range was, which was some patients were 0%, some patients were 100%. And that's why in this patient, you treat them as though there could be 0 to 100. This side needs slightly less than the other side. A lot of it's done by palpation, so I'm making sure there's no deficit. You could fill the lateral brow here if you want. Most people don't need much in the lateral brow. She just needs the tiniest bit way over there. And we're doing this under twilight sedation, so some of the stuff irritates her just a little bit. So now she looks symmetric over there, and it feels symmetric. So we're doing a lot of this by palpation. Going down to the face, she doesn't need anything here, doesn't need anything there. Zygomaticus, it's always beneficial, not always, on most people, on this flat over here to put a tiny bit of volume. The zygomaticus spans across from the nasolabial fold up to this lateral part of the orbicularis. Orbicularis, you can see the margin of the orbic. You can see it here. You can actually see the color change as it gets to where orbic is not there. So orbic is right around here, and zygomaticus comes right past it. Now there is a fascial expanse that continues from the zygomaticus back to the hairline and even under the hair in some people. Sometimes it's muscle, sometimes it's just fascia, but the zygomaticus continues all the way. If you have an indentation here, when you smile, you get flexion only up to that point, and it indents, and you get this kind of cheek and a stoppage point there. Some people would call that smile block, even though it's not a true smile block. If you have no volume there, it indents. If you have good volume there, then it contracts evenly all the way across, and you get a better appearance. 18 gauge. Give me that on the next one. So you come into the hairline over here, you follow the zygomatic arch, which is back over here. And we're going to enter into our little hole over there, push down to the zygomatic arch. You might see the frontal nerve jump. And we get down onto that malar flat, and we're injecting under that midpoint of the zygomaticus, which is above your zygomatico-cutaneous ligaments. You can't really expand the area of the zygomatico-cutaneous ligaments very well without doing multiple passes in different planes. Just so you understand that about areas that we call ligamentous or retaining ligaments. I'm doing just a little bit into the temple right there to smooth the transition, because when you pop out the cheek, the temple looks deeper. So here we're coming along the zygomatic arch, and you want to make sure you go horizontally along the zygomatic arch. Most people have a tendency to increase the volume along the contour line, which goes up this way. But realistically, the cheek goes that way. So you have to go horizontal once you get the zygomatic arch. And if you want to fill this area of the zygomatico-cutaneous ligaments, now you're doing retrograde passes, because you have to get into multiple planes to revolumize the area that looks indented in the zygomatico-cutaneous ligament region, which is a really nice thing to do, because you can see how it gets rid of that indentation there. So now she has proper support, and when she smiles, it's going to be nicer without an indentation there. It's also important because during a facelift, especially a deep plane, your deep plane entry point is right there. And when you elevate that off, you denude the muscle, and you move it, that muscle ends up hyperfunctioning even more. So we're going to go to the other side. Here we're going to make a tiny little poke, again at the lateral part of the zygomatic arch. And I'm going to come down to the malar flat, which is this flat area, which is above the point where your masseter inserts. And that's where the zygomaticus has its issues. So I'm just depositing there and then retrograde dissecting a bit. We're going to do a little bit in the inframalar region right here. And again, if you want to go through zygomatico-cutaneous ligaments to expand them or reinflate them, you have to do it usually in about 2 planes. One superficial, one just under that and then it expands nicely. If you just do it in one plane or you go subperiosteal there, it's not going to do anything. It's more about revolumizing the tissue that's contracted over there, just as you do in the pregal sulcus. So that was 2 cc's, and that's all she needs. Now we're going to go into the pregal sulcus. This side is very easy because it doesn't have much of an indentation, as we saw preoperatively. And the pregal sulcus is where your mandibular ligament is. The mandibular ligament is not a ligament that forms over time. It's not a ligament that needs to be released in most people. However, most surgeons don't fully understand the mandibular ligament and its function and what it does. It is just a tethering ligament in the pregal sulcus. It is osteocutaneous in nature, but what happens and why it becomes prominent and why it becomes prominent when you lift up on the face here is because it's missing volume. That's why. It's not because the ligament contracted over time by itself. It's just missing volume. So if you come into the hypodermis here and you refill the hypodermal fat and the mass fat, you'll see that as soon as I lift it up, it's going to be gone. And it's not that I cut the ligament. I did not cut the ligament. All I did was revolumize the area that was atrophied over time. And this allows the skin to be supported and not collapse onto itself, which is what's happening when you see those indentations. So just grafting into superficial layers. And then now if you see, if I pull up on it, it's gone. Do you see that? I didn't make it up. It's gone. Mandibular ligament doesn't exist anymore. So does the mandibular ligament need to be released in most people? The answer is no. It needs to be reinflated. The other thing to realize is the color of this is better because now there's yellow under the skin. The color of fat is yellow, and when you're missing the fat under the skin, you start reflecting muscle in the mentalis and the depressors, and it gets darker. But as you see, the darkness is gone. It's brighter now because we put the color yellow under the skin, and I didn't cut the mandibular ligament, and you don't see it anymore. You don't see it in any direction. Here again, we're making our entry port with an 18 gauge going through the 20 gauge cannula. As you pull up, you'll see there's restriction here. Now we're going to inflate it, and the reason for inflating it is to improve the appearance of the mandibular ligament or pregal sulcus, and the other is to get rid of the witch's chin. Now to get rid of the witch's chin, we have to go and inject inferiorly under the chin here to give support at the junction of the mentalis and the platysma. And a lot of this is done by palpation. I can feel there's a defect or a deficit right here. And it's a very three-dimensional type of filling because there you go. So the mandibular ligament's already gone. You don't see it anymore. The color is already better. It's brighter. And now we're going to continue into the crease right down over there where our witch's chin was forming and trying to support and push out the junction of the mentalis and the platysma so it doesn't indent when she smiles, because right now it indents and it follows up this entire line onto the face. And you can fix this with filler, you can fix this with fat. Fat's always better because the color of fat is yellow, but you see all that's already fixed. So just with a little bit of fat grafting, I did a very small amount, 1 cc, I fixed all the way to this side of the witch's chin and the entire pregal sulcus, which was indented, and now you see it's not contracting anymore. Before it was contracting and it looked tethered, it no longer looks tethered, not in any direction. It just rotates perfectly because it has adequate volume. Right here. Right now I'm going to support the area behind the witch's chin. So I'm going deep and actually fat grafting under the mentalis here and platysma at the junction. And that's going to help prevent them from pulling in deep when they contract. So the medic muscles of the face need support. If they don't have proper support, they start to hyperfunction and they indent, just like you saw laterally with the zygomaticus. That's what happens to it over time. So there we go. I want to make sure we're symmetric, so you always look at it from up top. And that's how we fix that problem. So witch's chin is now halfway fixed. Mandibular ligaments are already of no consequence. So we're done with the chin without any real volume augmentation. Now we have this crease which follows up. Now, it's always important to follow the lines of creasing and shadowing because that also affects the appearance of where they terminate into the sulcus. So if you have a deep nasolabial crease, it makes your nasolabial folds look deeper if you have a deep alar crease. If you blunt it with cartilage grafting during a rhinoplasty, your nasolabial folds look better because they don't look as deep because that's not as deep. Same with this. You want this not to look as deep. So what we're going to do is fashion a little bit of nano fat, and we're not going to filter the nano fat. It's just going to be broken down nano fat. So we use a 1.2 millimeter cannula stopcock, and we're just going to pass the fat back and forth, and you see it goes from a golden orange. It'll start turning to a creamy yellow. And that means you've broken up everything, and the orange is going to be from a little bit of beta carotene and blood supply, and then now you've popped everything open so it changes color. It turns a little bit creamier in its tone because the little beta carotene's all popped up now. So we're going to get a 22 gauge needle, please. So you can see the consistency of this is pretty thin. It smears. It's not real fat grafting. We're using this as a matrix for like a stem cell rejuvenation. You can inject it out of a 25 gauge or a 22 gauge. You want to come directly into the dermal epidermal junction right there and do retrograde injection. Now, it doesn't matter if you get a ridge when you do this. It will disappear within about 2 weeks. So you follow right in there, and this is how you get these superficial rhytids. And it's minor things like this that will keep the patient, this patient doesn't complain, she's amazing, but minor things like this which will keep the patient from complaining afterwards, which is really our goal in this world. Can I get another 22? So here you can see superficially as we inject, it turns a little opaque and white. And that's it. Okay, we're done there. Now we go to the surgery. So before we start, you notice safety measures. We always have pink within the solution for the numbing medicine. That way, that's cyanocobalamin, which is vitamin B12. You always know which one your numbing solution is, and since we mix the solution ourselves, this tells us that it's all already been mixed. So safety number one, safety number two, we always pass the knives and any sharp instrument around the field, never over the patient's face. Right here, we're using a 15 blade. If you see, we're using a Persona blade, which is a little bit sharper and more precise than the standard Baird-Parker blades that most people use. You don't need to use a 15 cutter. So you want to extend down yourself and a very light hand as you come across to make sure that you stay exactly within your markings. These markings are very sensitive because even a ½ millimeter of change can be noticed. Now, really, it's a millimeter, but let's exaggerate a little. So here we come across, and we're using a 15 blade again with a light hand, continuous motion. If you need to reestablish yourself, it's fine. It's easy to get back into the same line. And you want to make sure you go perpendicular through the level of the SMAS down to the orbicularis to make sure that your dermis is flush with your hypodermis and SMAS. And you come over here, you pull down for yourself, make the incision along line 1, which is your upper limb of your excision. Upper limb over there. Patient's under twilight sedation, so you sometimes have to give them a little extension so they can breathe. And here you see we've now completed it, and we want to let it expand downwards, so we just make little tiny incisions like this with a light hand so you don't make it bleed. It's a very vascular area, and you can see here we just pull up the dermis, epidermis, and SMAS, and you want to elevate all these together. On the superior portion, you'll see that we have the inferior alar artery at some point right here. It's buried. You can see it right there. And what we're doing is excising the SMAS. Now the SMAS layer here is a fascial SMAS that lays over the orbicularis, and you can see she's got a thick dermis and a thinner SMAS. Most people have a thin dermis and a thicker SMAS, but everybody's different. As you get over here towards the central portion, it gets thinner, and you continue by pulling
and separating the orbicularis oris muscle. And then once you get mostly across, then you can flip it over and continue from the other side. So you release the apex, make sure you get all the fibrofatty tissue out of there, and barely just touch it with your finger as it goes, and that way you can avoid bleeding. Now you'll see the SMAS has some fat in it. It's got other fascial components and a lot of hydration. It's a very wet layer, so it's a very sensitive layer to hydration and hyaluronic acid content. When you open this up, you can see that even though it was a 9 millimeter excision, she's open like 15, 14 millimeters there now. That is a sign of what we would call orbicularis hypertrophy, or incompetent orbicularis, which is very common in patients who need lip lifts. When they have poor incisive display, they don't have good tooth support for the lip, and they end up getting this kind of flaccid muscle over time. What I'm also doing is assessing the nasal base laxity as I'm stretching it down, and that just gives me a little indicator of if I need to suspend someone up more or less. So the indications for doing muscle suspension or orbicularis plication are if you need more incisive display, or if you have a mismatch between the height of the skin, the muscle, and the teeth, which they should all have relatively the same height. So now we're going to do the deep plane dissection. You can come right over this vessel right here, dissect over it so you don't make it bleed. If you make it bleed, not the biggest deal in the world. You can cauterize it. And we always use bipolar cautery. Monopolar cautery is not an instrument for coagulation. It's better for cutting. Bipolar cautery is definitely the better way to go. Now, laterally, as you can see, the SMAS is getting thinner here, and the inferior alar artery comes in there from the facial artery and the labial. So you just want to spread bluntly over in these corners, just like this. Spread bluntly so you don't cut that vessel. If you cut the vessel, you're not going to have any issue with blood supply, but it does bleed, and that's a bad style point. Over here, we're going to elevate over. I'm using my finger to give me the tactile feedback for depth, to make sure I'm staying at the same depth the whole way across. And this little vessel, we transected it. That's the upper portion. That's the lower portion. And you just get it to stop. Perfect. So what we want to do is dissect down only as far as needed to get the SMAS to roll over the orbicularis without affecting it. Now, hers bunches up a lot, so we may do just the tiniest bit of muscle suspension for that reason. So let's get a marking pen. We really want to do minimal muscle suspension on her because she doesn't need much increase in tooth show. So we're going to do just this lower 4 millimeters, let's say. Whereas if you wanted to get more tooth show, you would mirror the incision. So if you did 7 millimeters of excision for 2 millimeters of tooth show, you could do another 7 millimeters of muscle suspension for another 2 millimeters of tooth show. So you always want to mark this before. Now we're going to go to the nasal base suspension, 4.0. We're going to use a 4.0 PDS here to make sure we fixate. So here we're going to grab this part that's the most tautic, grab the hypodermis, which is right here, and then we're going to reverse in and pexy up the entire nasal base, just like that. And you'll see that it's going to push the sill deep to the face and upwards. The maxilla, as it ages, can lose some volume, but also the orbicularis rotates clockwise. So the orbicularis rotates clockwise down the face. I didn't get a great grab of it, so I'll have to do that side again. Here you can see we're going to grab the hypodermis. And what we're trying to do is immobilize it so during the healing course, it doesn't tend to pull downwards. Because no matter how good you think you are at getting rid of tension, it's a dynamic area, and dynamic areas will always have dynamic tension. This one fixated a little bit better. And to make it symmetric, you always want to make sure that you're at the head of the bed where I'm located, and that helps you see all the asymmetries at the nasal base more effectively. This is a 4.0 PDS on a PS2 needle. And you can see that that pexy the sill inwards now. And now we're in a good position. So if I pull down, this should be fairly fixated. That's pretty good. Fairly fixated, pretty good. Okay, let's get a 5.0 PDS. Now I'm going to show you how to do a muscle suspension, orbicularis suspension. This is a minor suspension. The key here is to understand that you're going to obliterate any function of that muscle, but it doesn't matter. It's altruistic surgery. You're sacrificing this upper muscle for the greater good of the rest of the muscle. Surgical altruism versus surgical irony is when you do a procedure that you think is going to help you and it really only ends up hurting you. So those are two things to understand about surgery: surgical altruism, surgical irony. So here we went through the nasolabial junction up through the caudal septum. So we're pretty fixated. However, if you stitch here, the muscle's going to ride up onto the columella. We don't want that. We want the muscle insertion to stay deep. So what you do is what we call a reverse mattress. You're going to enter and exit around the same area, right over there, coming back towards that nasolabial junction, the natural nasolabial junction right there. And now when we stitch the orbicularis upwards and imbricate it, it is going to stay deep into a natural position and reset some of the aging of that upper lip and that upper orbicularis over the alveolus as it wraps around the turn of the alveolus. Here, when we're looking at the side, you can exit deep and enter deep without a problem, so you don't need to do a mattress. And you just grab your orbicularis, and we are imbricating. And now, the negative of this is just that they get a little increased sensation of stiffness in their healing, but their muscle functions perfectly. And I always warn the patients you might have that little sensation of stiffness, and that it can occur whether or not you actually do the muscle suspension. So it can happen regardless or irrespective of that. So we're just grabbing one by one, and you're going to do 5 sutures. So you do your center line, your peak line, or your paramedian. You skip the intermediate, because they tend to look too angry when you do that, and you go to the diagonal. Now the diagonal line is going to be a horizontal mattress. So we come down into that junction, push down deep, exit. I'm grabbing periosteum. Now I'm going to do a horizontal mattress where I'm grabbing the muscle, going in to out, out to in. And now we've created a horizontal mattress, and we're going to bring in that entire corner or diagonal side. You see as you tighten it up like that, leaving the intermediate line undone. The intermediate line will anyways become incorporated when we do our nasal base suspension sutures with suspension of the SMAS. So here you can see there's one area remaining. We're going to go enter deep there, get the periosteum, and we're really tacked in profoundly. And you want to grab the corner of the muscle over here and mattress it back inwards, and then tighten it up just like that. So everything is now symmetric, and you can tell because we're looking at the tooth show and it's all symmetric over there. Now we're going to skip to our SMAS suspension. And what you want to do is incorporate your nasal base suture. So we already stitched over here. I'm going to go around it. It's incorporated into the stitch, and I want to exit inferior or deep to the hypodermis. You do not want to grab the hypodermis or dermis. We're just grabbing the piriform ligament, or in this case the caudal septum, and then on this side we are grabbing only the SMAS. You see the dermis is in my left hand, the SMAS is in my right hand. No SMAS sutures here. And now I want you to see, as I close it, this is the part that's everyone's favorite in the videos, you'll see that the lip comes up to the nose. The nose should not move down, not even a millimeter. So watch this. You see the lip moves up to the nose. The nose doesn't move down, not even a millimeter. It doesn't take tension. There's no tension there because you're rolling over the muscle. It's been released. That's what we call the deep plane release. If you don't want to call it a deep plane, don't call it a deep plane. It's technically a middle plane. But what it means is that it's a sub-SMAS release off of the orbicularis. So the nomenclature doesn't matter. Call it whatever you want. There we go. We grab the SMAS over here. And you always want to have a little bit of a medialized vector on this so you don't widen the philtrum. You don't want to widen the philtral columns from each other. And we're using a little tenotomy scissor, both as our dissection scissor and as our suspensions suture cutting scissor. Again, I'm going into the junction, exiting before the dermis. Let's get another 5-0 PDS. Grabbing just the SMAS, nothing else. Et voila. Now we're going to grab the intermediate line. This is what I was mentioning, is this part's not stitched. However, now, as you go around the intermediate, you incorporate it. So now you did do your muscle suspension there. However, it's going to be much less exaggerated. Here you can see there's a lot of redistribution which wants to happen. We have to medialize it like this. So I'm going to grab a little lateral to my intermediate line to ensure that I pull it in the right vector. Everything gets centralized. That's perfect. See, so now the intermediate line aligned perfectly with the intermediate, even though I grabbed it more lateral. So you just have to accommodate for those little changes that you'd expect when you have bigger redistribution on that side where we're taking more skin. This side is not going to be a problem because the amount of lateral skin excision was pretty nominal, or the disparity between the I and the D. So again, grabbing the SMAS over here, literal lateral to the eye line will get it, the eye line to align. And you can see on all these stitches, they are pulling up. The nose is not pulling away. And we're keeping an eye on symmetry because at some point you may accidentally grab the muscle and snag it. So you want to make sure that your lip stays symmetric and you don't get this inadvertent pull internally. If it's an internal pull that happens in here, it happened because you grabbed your muscle. If it's externally asymmetric, it's because your skin or your SMAS is asymmetric. So if you see something pull in there, it's because you hiked the muscle up too high. That goes to the next point, which is muscle suspension decreases the amount of vermilion exposure and vermilion roll you get with your lip lift. So if you do want to limit the amount of volume, that's another reason that you do a muscle suspension, because it'll lift you more vertically rather than rolling the vermilion and everting it. Now we're going to a 4-0 vicryl, and you can see here we're going to get into the corner, push out of the corner there, right in the apex, flip around your needle if you can grab it. And here you want to grab the dermis, sorry, the SMAS, not the dermis. Flip it around. If you grab the dermis, you can get ischemia and ulceration, which I got one back in 2014 and haven't gotten it since. So it does happen if you grab the dermis. Dermal sutures, without exception, can cause more ischemia because they compress the dermal plexus directly by compression forces. So between the diagonal line and the apex, we're throwing 2 of these 4-0 vicryl sutures with a PS2 needle to close and medialize the area between the apex and the diagonal line. You can see we're getting a nice SMAS bite on all these. No dermis, go right through the junction to get the best medialization. You don't want to catch a bunch of soft tissue there or else it won't medialize. Just like that. So you can see the skin is well approximated without any dermal sutures. You don't want dermal sutures because they spit and they cause ischemia. So if you can avoid them, avoid them. If you need them for something, use them. They're great. Perfect. So you can see how well approximated it is. You do get a little flare on the nostril towards the end because the lip is pushing into it, which is how you want it. You don't want the lip pulling on the nose. You want the lip pushing into the nose. Over here, we're going to do the diagonal suture. So on this patient, we performed nasal base suspension, which is fairly routine, but you can exaggerate it and do more if somebody's really tautic. We did a minor muscle suspension or muscle imbrication. we did a lip lift, and we're doing a corner lift. Now, a subnasal lip lift. Now, the other thing that we incorporate sometimes is VY advancements if we're trying to improve the shape or the volume of the upper lip. The best use for this, in my opinion, is when you are trying to improve an M-shaped lip where the mucosa is in the shape of an M along the wet-dry border, and you want to make a smooth arc. And since we're not doing that on this patient, I will just demonstrate what you're trying to achieve. Is typically you have an indentation over here in the paramedian tubercle and an indentation there, and that gives you an M-shaped. To improve that, you can either trim behind the central tubercle, which you have to do on the wet mucosa, or you could do VY advancements. And if you're going to do VY advancements, you come lateral to the central tubercle, towards the lateral tubercles, and you extend the the base of your VY plasty from behind the wet-dry border, lateral to this peak, and it ends at the diagonal. So those are the two lines, and then you take it all the way internally as a V, and you can advance the V usually about 4 or 5 millimeters without causing people's lips to become a little floppy or to compress too much against the teeth when you smile. So here we're throwing in that other diagonal suture between the diagonal and the apex. So you just do a forovicral with a PS2, and that approximates everything perfectly. Worked out fine. Now we're going to finish by closing off this diagonal suture, which was hanging. And then we're going to get some local anesthesia before marching to the next part of the surgery, which is the epidermal and dermal closure with interrupted sutures. So we're just injecting here into the corner lip lift, which is the next part, because it wears off usually by this point, and corner lip lift is very vascular. And then we're going to numb the next portion, which is the eyebrows for the brow lift. Always want to inject about 15 minutes ahead if you can. Okay. Now we're just suturing. At this point, the entire lip lift, the lip should be opposed to the nose without any tension. And when you close it, you'll see there's no dermal sutures here, but the mass is pushing in to the nose. And your choices here of sutures are subcuticular, interrupted, vertical mattress, running, locking. You can do any of those. However, I've done a lot of these, and I've tested actually between the best two versions, which is vertical mattress and interrupted. I did 1,000 patients vertical mattress. I did 1,000 patients in a row interrupted, and the more manageable outcomes were with the small bite interrupted. Big bites are worse. Vertical mattress, you get epithelial bridges, and the biggest improvement, or the most manageable, or the lesser of the evils, is these interrupteds with little bites. And it's better than the other types of suturing because you can really manage the level of the incisions where one side of the incision is not higher than the other or has any step-offs or anything like that, and it redistributes nicely. Now, the three most important ones are the central three. After that, you can just march it inwards, and it's going to close perfectly. And so you want to go to the apex here, close the apex first, and then you can just march everything else inwards, and it will redistribute appropriately with no problems. I like to take these sutures out at day 3 and day 5, or day 4 and day 6, or day 3 and day 6, anything that works out for your schedule. And I don't like to leave them in too long because I put so many of them. And the more you put, the more problems you cause. Now, leaving in a suture even 3 days can cause permanent issues. So you can see these little epithelial tracts and bridges form months later from stitches that you left in just 3 days. And that's either from microulceration, which occurs from the pressure of the stitch as it bridges across the incision, or from the skin cells crawling across. Again, as I said before, like little ants, they can crawl across where your stitch is while it's sitting in there because they have little pseudopodia, and it can actually crawl across the stitch because you can epithelialize over a stitch, and you won't even see the couple cells, but then as the future cells follow those cells, they can form these bridges. Again, here we are closing from outside in, from the apex in, and that's what you want to do when you have a perfect fusiform incision. If you don't do that, and you try to split the incision or stitch upwards, what you're going to see is that this area can get bunching in the vertical over here, and you get dermal hyperplasia or dermal thickening under there. So that's why you want to always close from outside in or from the apex inwards. It's super, super important over here. And if you really understand the idea of the flap and the direction of movement, you'll see that everything here comes on a hinge and hinges back upwards. It's always important to understand your fulcra, where your fulcrum is and how you're going to hinge around your fulcrum. If you understand the basic physics of that, it's going to help you a lot in brow lifting and face lifting and lip lifting, where you can really take advantage or mechanical advantage of those things and avoid problems with dog ears, and understand the difference between vectors of lifting relative to the fulcrum. So it's those tiny little things that affect scarring over here. See when you push it down. Yeah. Because the lip is supposed to be slightly deeper than the nose. There's always a question of over-resection. What if you over-resect? Can you fix that? The short answer is no, you cannot. Yes, there are ways to fix it in severe over-resection, where you can try to do volume expanders, you can do skin grafts, and you can do things where you're pretty much turning it into a Mohs reconstruction with a defect. However, in general, you cannot fix it. So your first go-to move for over-resection is to actually shorten the teeth if possible. And you could do that either if they have a big alveolus. It could be orthognathic surgery, where you impact the entire alveolus with Lefort fractures, or you can do dental impaction by bringing the teeth into the bone with orthodontics, or you can just trim the teeth, or if they have veneers, that's the best. You just remove the veneers and put smaller veneers. But that's your first move if you have over-resection. It's the easiest move. Now we're doing the corner lift. You always put a bolster in under the corner lift, stretch out your apex, your medial apex, and you want to do a nice, gentle incision on that lower border, following the border of your vermilion, coming out usually at a 45-degree angle or so, or sorry, 90-degree angle or so, and then gently touching the apex, and then you can put more pressure gradually as you come down, and always wrap it back around inferiorly because it has a tendency to continue onto the face. The SMAS here is very thin, so you don't need to go very deep. Make sure you get the entire apex out on both sides. And voila. You can pull up here on the excision and go right under the SMAS, which you can see how thin the SMAS is here. It's about 1 millimeter thick, whereas in the other areas on her it was about 2 to 3 millimeters thick. And the SMAS is a slightly gelatinous, slippery, slidey, greasy layer, which means if you ever put hyaluronidase into your injections, you will obliterate that layer, and your dermis will be sticking directly onto your muscle, and it becomes a very difficult or stickier dissection, just like in the upper eyelids. Now here you can see we go from the pars peripheralis, which is under the SMAS, to the pars marginalis, which integrates and intertwines into the SMAS. And you can see we're making a flap equally as thick as the SMAS so we can suture to it appropriately. But you do have to cut through those fibers. The lamina propria is your hydratatory layer or SMAS layer of the vermilion, of the dry vermilion. Okay, so here we're going to do closure, which is going to be going through that SMAS layer. You can see we're right under the dermis. If you have good eyes, you can see that little dermis there, epidermis. I'm right under the dermis. Flip over your P2 needle, pull out your apex, align it, grab your alignment point, and just push into it with your P2. Rotate it around on that top part of the lamina propria. Again, lamina propria is intertwined into the orbicularis fibers, and that is where you get the different character of the vermilion orbicularis versus the filtral orbicularis. So they act differently. The filtral orbicularis squeezes against the teeth and doesn't exert much effect on the superficial part of the skin, whereas the vermilion orbicularis is intertwined within the lamina propria in the submucosal region and can give lip character, definition, wrinkling, puckering, and all the other characters of the orbicularis. So it's the same muscle, however, it has different functions. It has more of a sphincter type function along the vermilion and just a squeezing type function against the teeth in the filtrum. Now you pull across and you keep aligning as you go. I want to make sure we're at the same level as we go all the way across. And you always want that bolster in there to help show you everything, but also so the patient doesn't move their mouth as much. Now she's asleep under twilight. However, if you have an awake patient, the second you take that gauze out of their mouth, they start chomping on the bit like a horse. And it's because their mouth is dry, they feel awkward, they have strange sensations. So it'll benefit you as the surgeon to keep the gauze in there as long as you can. The second you take it out, they'll start moving their mouth around. And it gets a little annoying. So there we go, let's get a 6/0 nylon. Now you can pull it out. Pull towards yourself, and you always want to close the apex first. Just like that. Always better to close the apices first. You're going to avoid a dog ear. And we're just closing as we march along. Tiny little bites, and you have to vector yourself back out just like that to close it appropriately. And you always want to keep an eye on that lower lip to make sure you're not pulling on the chelion too hard. A little tiny pull on the chelion is fine. It's not going to be noticeable as anything afterwards, but a big pull on the chelion means you redistribute something incorrectly, and you don't want to have a joker's smile. Reversing a joker's smile would require a Z-plasty around the commissure. Never had to do that. Hopefully you never have to do that. So little tiny bites as we march along. And now we've closed this side of the apex. So we're going to march along to the next side of the apex medially. Medial apex, you pull to straighten it. You throw in your little stitch, and your little stitch aligns it perfectly. There we go. You can run this if you want. However, remember, if you run the stitch, you cannot take it out at different times. And we like to take out half at day 3, half at day 5 to decrease our suture load faster in recovery. So you see here I'm superficial. I grab deeper to keep it at an even level. You don't want any step-offs, any ledges. You want everything to seal pretty nicely. Now if you can get a little eversion out of these stitches, fine. That's great. It's kind of hard to. Not absolutely necessary. These areas heal very, very well on the large majority of patients. Some patients do require modulation with 5-fluorouracil, which is off-label, or CO2 laser. Never do CO2 laser and 5-FU at the same time. 5-FU inhibits DNA synthesis, and it will shut down your healing immediately. And if you have something in active healing from either laser, which you just damage the skin, or from surgery recent, it'll just break down. So don't do 5-FU in anything that's actively healing. Let's go to the other side. Here again, we put the bolster underneath the lip, and you can come across, make your triangular incision, very light-handed as you're coming across. Mainly when you get to this apex, you want to be super light-handed. Now, instead of coming all the way from here to here, you lose the support. You want that counter tension. So leave that attached. Come make your apex first, just like that. That way you don't transect it. Now that you have that and you use your counter tension, now you can release the rest of the incision and your counter tension's gone. But it was beneficial for that tiny little portion over there. Now we're going to excise using a little tenotomy scissor, get right under that apex, and you want to preserve the volume here, so don't accidentally cut more than you need to. Stay right under the dermis there. It's a very thin smash. Keep your volume there or else you're going to get inversion and indentation. Now we're going to elevate, leave a nice thick flap, push forward, and then cut straight down to keep this flap of lamina propria. Release around the corner of the commissure, not too much. You don't want to cause any dermal injury from doing that. Now we've released everything over here. Let's release a little bit more. You could do vertical spreads if you like, just like that. And again, you can see the lamina propria and the translucent mucosa from this side. And then you go to this side, you can see it's translucent mucosa. You let it go. Blood supply runs through it again, makes it red. Most people do not have pigment in their upper lip. Some people do. However, the only pigment we have in that area is melanin. When it occurs, you'll see dark spots. The red that you see is just blood supply reflection through the lamina propria, which is intertwined with orbicularis fibers, and then the orbicularis of the philtrum deep to that. So you have your pars marginalis and peripherales both reflecting color into the vermilion. It's hard for people to understand that unless you've done a bunch of these, and then you can kind of see where the muscle actually lies. So here again we're throwing a 5-0 vicryl and a P2 coming across. You want to grab it at the same exact level so it aligns properly. Pull downwards so you don't tear any tissue. And people tend to tear tissue because they don't lift the lamina propria properly. And the thing is, it's not a very obvious plane like you have in the philtrum where the SMAS is overlying the orbicularis. The SMAS and the orbicularis are one in here, so you just have to kind of go create a thick flap. And you are cutting through the marginalis fibers ultimately over the pars peripherales, over underneath it. 6-0. Now here she has a little bit of bunching, and somebody who has bunching like that and they have a depressed commissure, I'll make a back cut right over there, bring this up right over there, and that's a type 2B, and then I cut away the excess. But hers will redistribute fine once I get rid of this gauze. So you want to close the apices first. So always do an apical closure. Avoid any unnecessary dog ears. Dog ears occur for two reasons. One is because of a discrepancy in length of one side of the incision to the other. The other reason is because you torqued the incision. And torquing the incision or shearing the incision can cause a dog ear even though both sides match up. So our job here is we know both sides match up, and you can avoid shearing or torquing of the incision by just closing the apices first. So simple, so easy. Perfect exposure of the lateral lip as we come across the elbow or the inflection point of the corner lift. That's where you notice if you pulled it too high, too low, not enough, too much. And as you see now, she has perfect exposure of that upper lip. And you want the lateral upper lip sitting on top of the upturn of the lower lip. So the lower lip comes up to the commissure, the upper lip vermilion sits on top of it just like that. So that's exactly where you want it. That's a young looking lip. It's also a sexy looking lip when you do that. And the lip is one place on the face that you can't be afraid to think about or talk about sensuality or sexuality. It is the orifice into your face. And it is a definite sign of youth, virility, sexuality. And when you do a lip surgery, you can increase someone's sexuality, whereas you can't really do that with many other areas on the face at all. You can improve beauty, balance, harmony, age, all those kind of things. But the sexuality or sensuality comes from mainly the mouth. Here you can see now, more symmetric on both sides. The curvature on both sides is better. We picked her up substantially on that buried side more than the other side. And you have full exposure all the way to the end of the lip. And the heights that you want to look at here are going to be the height of the vermilion, of the dry vermilion. You want it relatively even all the way across and exposed all the way to the edge. The other is going to be the height of the lip to this horizontal plane. We drew that horizontal plane that comes across right over here, and you can see that the height of the lip is relatively the same as you follow that horizontal plane over there. And that's how you know you're not getting any steep drop-offs to the side of the mouth. Now, naturally, you can have big drop-offs on somebody. Iatrogenically, if you operate on somebody, you do not want a steep drop-off because it's more exaggerated than would be naturally occurring on anybody's face. Our incision placement is here. We call it a hybridized incision, meaning it's a combination of two incisions that you would have otherwise here and here. You could just put it right across there because the whole idea is that fixation doesn't matter, which means you don't have to have multiple points to provide multiple fixation areas. What you're trying to do is just reset the scalp in the glide plane, which is the deep plane, back to where it was, the entire scalp, and it'll stay there. It is a glide plane, which means no matter what you try to fixate, the parts that you can't fixate are going to float down anyways if they have any tension on them. So you have to do the surgery without tension. It has to glide back easily, which means that the surgery really depends on all the release, not the fixation. Most people's focus is on the fixation. However, you cannot fixate glide plane in general. It's going to fail as it goes down, or you can overlift somebody, which is the other problem. So here you want to make a beveled incision. You can see the hair follicles are pretty steeply vectored over here because they're temporal. Temporal tends to go down that way, and then you can have your frontal to parietal hairs coming back this way. So you want to make a pretty steep incision over here as you're beveling in there on her, and you can see that you're paralleling those hair follicles. And it's about a 2.5 centimeter incision. If you're America, it's 1 inch. So there we go. We're going to do double. Now we want to declare our deep plane, and we show it by pulling back on the dermis, and we're going to spread deep over here through the temporoparietal fascia. And as you elevate up, boom, that's your deep plane. As you're down, no deep plane. Above, that's your deep plane. We're going to do scissor spreads in between these little fascial connections to see what's in there. Sometimes there's a vessel, sometimes there's a nerve. If there's a nerve, and it's a big nerve called the nerve of Kinsey, you want to leave it. If it's a vessel like this, you want to cauterize it. Those nerves you can leave. They are little sensory branches, and you can try to cook around them if possible. If you cut them, not the end of the world. You reapproximate things, they tend to grow back in, although it is a long distance from the beginning of the nerve, so it would take a very long time for that to grow all the way from there back over here. Now we're going to get down over here over the layer of the muscle or the bone. Depends on where you are. Inferiorly here, we're right over the muscle, and now we will get the Ramirez 4 elevator, which is a curved pancake, which is perfect for this procedure because you can dissect from 3 sides of it and it curves beautifully. Now up here she has a short temporalis muscle. Some people have a taller one. So we're not determining yet if we want to do bone tunnels or muscle suspension. We do whatever's needed. However, you make small movements, you're under periosteum, and you'll see that it just glides. Now technically your deep plane or your middle plane is over periosteum. However, when you're doing a surgery, your plane of dissection here, in order to maintain a flap that you can elevate, is subperiosteal. So you want to release all the way back to the occiput. So we're all the way back there, automatically to the occiput, and this allows the entire scalp to reset. If you don't do that, the scalp is going to push back forward onto you. Laterally over here, we're going to make small movements to get on top of that muscle. And we are now in that also deep plane. And you can march down, forward, just like that. Not much to see. Nothing to see here. Nothing to do. It just goes very, very easily in that glide plane. It doesn't take a lot of force. But you do have to release the conjoint tendon, because the conjoint tendon, which is here in the middle, is the fixation point for your 2 parts of your deep plane. The deep plane here, the SMAS, is the temporoparietal fascia. Here's your frontalis. Here's your galea poneurotica. That's all your SMAS. If you don't get rid of the connection of that conjoint tendon all the way back here, you can't reset the SMAS. And the whole idea here is to reset in the glide plane. Now we're going to come from this angle over here. You can see you're just opening in that same deep plane. So now let's get the retractor. We don't use an endoscope. This is an endoscopic approach. So we're using a lighted Alfrecht retractor. The light is over here at the end. So here we are on the superficial layer of the deep temporal fascia. This is your glide plane. We're using the lighted Alfrig to march forward, and we push down, and it should just open up that plane without any resistance, because a glide plane should have no connections. Now we go over here, and you can now see the temporal fat pad, and the place that it transitions is right here at the hairline. So if you look outside, you're usually at the hairline here. And that's where the temporalis starts to go deep into the temporal fossa, and the fat pad sits in this region on top of it, which is why when you see temporal hollowing, most people are hollow here where the skin is, not where the hairline is. When it's hairline hollowing and they look really thin back here, it's because this muscle has atrophied, which is your temporalis muscle. Now, some people hypertrophy here and they get thicker, and you can actually Botox this without much harm. Now, getting back to over here, you can see this fat layer that is encapsulated. It is a discoid fat layer that continues under the superficial layer of the deep temporal fossa. So when you're injecting fat, you really scrape down into bone and you just push forward, and it'll automatically end up into that encapsulated fat pad. So you do not need to inject fat in an open surgery. You can do it easily just by scraping it and pushing forward and keeping it into that fat plane. Now you want to march medially over here and inferiorly as you go, and you're going to do little spreads, and you're using your retractor in this hand to pull up and show these little spreads. Now you can see here that you pull and you start to see that sentinel vein. And the sentinel vein is not really of any significance other than it's something that can bleed, and you really just want to release as much as you can around it without making it bleed. Medially here, you can start pushing down on this decussation of fibers, which is called the conjoint tendon. Pull up on it, and you just push down on it just like that in a perpendicular fashion. Tends to open up, and it'll connect it with the decussation around that sentinel vein, which is right over there. So once you've released this conjoint tendon all the way down to the orbital rim over here, we've visualized already most of our dissection. You can see it all, so you don't need to worry about an endoscope. Now, I know my sentinel vein is right here lateral to me, so I'm going to put down the retractor, and now I'm going to do a release over here around the brow periorbita. Now we have our retractor over here. We're going to go by manual palpation. So you put your finger on the brow, and you push down small little movements with the spatula tip, and we're going to release around the orbital rim, and you want to march laterally on the lateral part of the orbital rim, scraping either under periosteum or just over periosteum. Now what you don't want to do is accidentally hit the canthus and release the canthus. So you got to stay lateral, and you release some of those attachments. If it's somebody who has loose eyelid, don't release those lateral retinacular attachments. So you release just right over there. Now you come around, we're going to straighten her head. I've already released on this side of the nerve. I'm going to skip the nerve, go to the other side, scraping on the bone, small rotary movements until we get to the contralateral corrugator and the contralateral vector of procerus. And you can release here off of the glabella just by scraping onto it. Boom, just like that. If you need better access, sometimes you can make an incision here and come release that. However, now you see we're all the way released. I want to make sure we're released all the way across. And then we grab our finger, and we call this the finger banging technique, where we will put the finger down into the brow periorbita here and release the brow periorbita. Large majority of people, this will release without any sharp dissection. So why use a knife? Why use a scissor? Just put your finger in there and push it, and it opens. Medially, I'm going to feel around the nerve. So I'm using palpation. I can feel a fiber of a nerve right here. It's in my finger, and immediately over here I can feel now the entire nerve bundle and branch. It's right there. Because our incision is placed more medially than the standard incisions, you can reach this with a finger. If you have tiny little fingers, I am sorry, this procedure will not work for you, and you might have to either do it with palpation using the dissector or use an endoscope. So now we clear everything back to the zygomatic arch, back to the posterior hairline, make sure our entire conjoint tendon is released, and we're set. Interesting to see is the brow is already released and back. It's released and it's elevated because we're supine. If you sit her up, it'll still fall down like that. Because we're supine, it falls back, which means you don't really need to do much elevation. You can see how easily it moves. You just fixate it right there, and it'll stay. You don't need to do much. Make sure there's no bumps from the fat graft. Now we go to the other side. Here we're going to make our curvilinear incision, usually about 2.5 centimeters, and on most people it crosses slightly over the line of the superior temporal line, and that gives you enough lift to go against the 3 vectors of aging. 3 vectors of aging are medial because of the corrugation and the procerus. You have a little bit of peaking that happens over this time, and that's the central part. And laterally, you get descent because this is temporoparietal fascia, has no suspensory muscles, only depressive muscles, which pull the lateral brow down. So the brow goes this way, that way, and this way usually over time. On most people, some people, all of it drops. Either way, we are designing an incision that is curvilinear in the opposite direction, and you make a parallel incision to the hair follicles coming all the way across. Because we're doing a video, we're going to extend it a little bit just to make visibility easier for the camera. Otherwise, you don't need that extra space. We get 2 double prongs as soon as we get through the hypodermis before we get to the temporoparietal fascia. And we place our double prongs in there, which we're going to use to spread like that. Elevate declares your deep plane. When you elevate, you have to understand that the skin and the temporoparietal fascia are one piece, one unit, and that's the case on the entire face. You don't want to delaminate those things. You want to keep them together. They are one unit. However, you saw as I elevated, what separated was that deep plane, or that middle plane of the face that we call the subsmass layer, or the deep plane. Over here, you're going to see some nerve fibers right over here medially. We're going to leave that one intact if possible, and then cut across that muscle. So it is not a sharp distinction between muscle and temporoparietal fascia. As you go to frontalis, there's a little bit of crossover between them. So here we are right on that deep temporal fascia, superficial layer right there, and then here we are on periosteum, as you can see. I'm just doing that to show you. So periosteum, deep temporal fascia, conjoint tendon will follow here and all the way back. What we want to do now is mobilize the glide plane of the face by releasing the tethering point, which is the conjoint tendon. So here we push back. It's easy to get onto the bone here. We're automatically onto the bone. You do little tiny movements. Once you get your area developed, you push, and that's it. And it just opens right up just like that, and you go all the way back. So this is a subperiosteal plane, minimal connections there. Now we're going to go along the superficial layer of the deep temporal fascia, push straight back, and it just elevates without any problem, no visualization needed. And then we have our conjoint. So you go across the conjoint, push straight back on it, and it'll open right up. And you can always flick from strong, which is temporoparietal fascia, to weak, which is your galea poneurotica. Strong to weak, strong to weak. That's the easier way to go, rather than weak to strong. It's always better to go from strong to weak, just like that. So lateral to medial in this situation. Now we're going to come down and visualize the remainder of our dissection, which is where your danger zones are for nerves and things like that. So you make small movements like this to get onto that fascia. And if you wanted to elevate and just push, you could. It just goes. Medially, you use the side of your retractor, getting up to the conjoint tendon, then you find yourself slightly locked. That's where you have to add a little bit more pressure in order to open it. Boom. And it just opens up. And again, strong to weak, and you're safe. Now for the remainder, let's visualize it. So we're going to get a retractor. Here we are now over the superficial layer of the deep temporal fascia. Just doing side swipes to open it up a bit towards the conjoint tendon. As we go deeper, we're going to push forward, grab our retractor, pull it up, push forward, and you just keep doing that until you get down to the zygomatic arch. Immediately over here, we're going to push forward until we get trapped a little bit. And then at that point, you can elevate up and spread down. Here you can see we're going to spread up, and you see your sentinel vein right over there. When you relax, it engorges. It is one of the tributaries that goes out to this venous plexus right over here that exists above the zygomatic arch, and then they go deep. They engorge here because of that traversing where they go deep. So you get this vascular venous arcade here, and they engorge. Now if you put filler over here superficially, these are going to engorge even more. But the sentinel vein is your last basal vein that goes down over there. Inferior to the zygomatic arch, they don't exist, which is why anytime you cut here along the temporal hairline, you get tons of bleeding because there's a bunch of these guys traveling superficially. Now, if you look down, here's your sentinel vein. You want to release medial, you want to release lateral, and then now we want to finish the elevation of the conjoint tendon. If you see over here, I've elevated subperiosteal, elevator of a deep temporal fascia. Now the decussating fibers that we have interweaving is the conjoint tendon. That is what immobilizes your glide plane on each side. For this, you just elevate up and you push down perpendicularly onto decussating fibers, and they just open up just like that all the way to the orbital rim. So again, we have our sentinel vein out here. We're safe. Here we're going to feel around the orbital rim. release with palpation all the way around, hold the head, around the orbital rim. Once it's released off the orbital rim, so inferior and superior like that, you do little tiny movements. It's very easy to slip here as I keep doing. So little tiny movements around the edge and you release it. Now we're gonna go medially, skip the nerve, go to the other side, procerus, corrugator. We're safe from any damage. Release there, and that's it. So now we're gonna come to the nerve on this side with a finger, called the FB technique. Release the periosteum all the way down around the nerve, and we're gonna release the periorbita, releasing around the nerve on this side, gently, and that's it. So now she's mobilized all the way across, and the key is that we've mobilized the entire scalp and the brows all in one plane, where we can set everything backwards to where it came from without crowding the brows, which is what's happened over time. So this is all we're doing in a brow lift. It's crowded over time in exactly this vector. Medial goes down, lateral goes down, and we're distending it back up. So I'm pulling things this way along the superior temporal lines, and the medial brow never goes vertical. It goes diagonal because you're pulling against this side versus that side. So now we're going to do our suspension. Here you see we're going to do 3 points of suspension across this incision. 1 medial, 1 central, 1 lateral. We grab, and you can see if I grab this part, if I go this way, there's bunching and pleating. If I go this way, there's bunching and pleating. If I go this way, there's no bunching or pleating on either side of the incision. That is how you mark your vector. So you can see here that it's going this way. This part is going to have a different lift, not because I choose so, because the body dictates it. If I pull this way, it's bunching. If I pull this way, it's bunching. If I pull this way, there's no bunching. So again, I mark my vector, Victor, right there. The last one over here laterally, you're going to see pulls up not this way, not that way, it goes this way, pulls up right into that muscle. So I can actually throw that one into a muscle, whereas these other ones are going to be into the bone. Now you don't choose if it goes into bone or muscle, you just lift, and wherever it wants to go, that's where you got to place your stitch. So you have to be amenable to doing that. Now we're going to put our little drill holes here, so let's go over to the drill. Now we're making our bone tunnels. We're using a piezo surgical instrument to make the holes. You can use that or a striker drill. Classically, I use the striker drill, and then more recently I've been using this piezo, which is nice. You can make smaller holes. Now, don't make holes in the scalp or in the calvarium without having bone wax in the room. Now, all you want to do is create about a 45-degree tunnel, and you just gently take your time and you let it go in slowly, just like that. It just vibrates and makes its way in. And if you want to widen your hole, you can circularly kind of open it up, just like that. Now, you will get some high-frequency hearing loss over time. I don't know what to do about that, but it is a wonderful instrument. And you create these nice little holes connecting the two sides. Now you come from this angle, and you just gently take your time. Whereas with the drill, you could just push right through. So that's the difference. With a drill, you just push right through. With a piezo, it just takes a little bit longer, and you can open up the holes just like that. And you can see that they're connected over there. Over here, we're going to do a drill hole again. Now we're through a fusion line. It tends to bleed more here, so we just have to make sure that we have bone wax in the room. Fusion lines, ligaments come off of them, and blood vessels go under them. There you go. There's your bleeder. Just hold suction there until we're done. So if it's not a big bleeder, you just take your time and finish up the other side. And you just make little circles, and it'll widen this so your stitch can get in and out of there a little more easily. Just like that. Let's open this side a touch more. Okay, bone wax please. So our holes are made, now we're going to place the bone wax. Come out, bone wax, you just kind of swipe across the two holes. And it should stop it right there. Give me a pickup. And so that's it with the bone wax. You don't want to leave a bunch of bone wax in there, although it's not generally harmful. Let's get the 2 of PDS, please. If you don't have bone wax, you have to drag a stitch through there and attach fascia to the back of your stitch to plug the hole. So there is an emergency way to fix it. Although most of those holes with bleeding like that, they stop bleeding as soon as you get your stitch through. So we bend our 2-0 PDS a little bit just to be able to get through this needle unless you have a smaller needle, but I love the 2-0 PDS for this suture. It's the perfect size, perfect tension, doesn't last too long. It's a great suture for this. 2-0 PDS. So you see that one started bleeding as we put the needle through, and then it stopped as soon as the thread compresses it, because the bleeders tend to stop bleeding once you get a stitch in it. Over here we're going to also pass through right there. This is why the piezo is nice. There's little really tiny holes that you make. So let's do this over here. And you want to throw a figure of 8 anytime you go into the muscle. So make sure to do a single pass like that, and you want your exit and entry to be on the higher points of elevation. Then you want to scratch and scrape both the superficial layer and deep layer of the temporal fascia. And now we're nicely anchored over there with a figure of 8. So while they're hanging, you're going to determine the vector of lift to those points. So you can see we pull across here, and just like that, that's the point. We're going to grab the temporoparietal fascia. You do not want to grab any dermis, just the TP fascia. If you grab dermis, you're not helping yourself. If you over tighten, you're not helping yourself. You're just hurting yourself. If you overcorrect, you're likely not understanding surgical principles in general. So overcorrection is introducing error into your recipe already, and we already have enough room for error. Overcorrection is not a smart thing to do. You want to correct appropriately and release appropriately. If you're overcorrecting, it means you're accommodating for failure that you're expecting to have. You shouldn't have failure. If you have failure, it means you're doing something wrong, because there are ways to do this without failure, without it dropping. It's just some people just haven't found the way to do that. So overcorrection is not a good principle. It should not be taught. Instead, it should read that failure does not dictate overcorrection. Failure means you lifted something incorrectly. Now, medially, you may rip through if you get to frontalis, so if it's weak, you have to do a mattress. Over here, we want to tie these one by one. Nobody should help you when you tie these. If they're helping you, it's not going to last anyways. It's going to fail later. You're in a glide plane. Human tissue, it's going to fail. So this is a 2-0 PDS, single knot, boom, that's it. This is your entire elevation. It doesn't overlift, it doesn't underlift, it lifts to where it wants to be, and it stays there. And what you're doing when you do these kind of lifts is you're really improving the dynamic function of the entire brow by repositioning the brow and the scalp so there's no crowding of the scalp. Here you go, 2-0 PDS. And again, you just want to get it snug just like that. I don't need anybody helping me. I pull it against myself to keep the knot there, slide the next knot down, and you're locked, and that's it. And this is where your brow lift will stay. And you've also resuspended the SMAS appropriately under the skin so you don't get atrophy of the incision, which means it looks more normal. And you can see as I'm closing, there is no bunching or pleating or dog ear on either side of the incision, which means I've lifted it into the appropriate vector. Now, if you hear that alarm is the signal for us to stretch. If you stretch every 1 hour for 30 seconds, you're going to have less neck problems, which I already have. So that is your entire elevation. You can see no dermal sutures are needed. You just push this back down, and you can see the entire scalp posterior is loose. Now, there's no dog ear on either side. If you have bunching on this side or this side, it's not something that you say it will settle. What you should say to yourself is, uh-oh, I lifted it in the wrong direction. Of course it'll settle as it fails, and your incorrect lift goes away, and your incorrect vectors start to go away as it fails. However, if you did a proper lift in the correct vectors, there should be no dog ears on either side of that incision. There's no exception to that. If you get dog ears, you did lift it in the wrong direction. That is a fact. There's also no reason to do skin excision in these areas. I have yet to meet someone who grew a yard of skin on their forehead as they aged. The forehead tends to crowd because the scalp moves forward. So skin excision is not helpful, with the exception of doing direct brow lifts or mid-forehead brow lifts where it might be necessary. So right now what we're doing is just closing the beveled incision. You cannot evert a beveled incision. You can only just put it back together. So little bites, put it back together. The bigger bites you take, the more hair you strangulate, the more hair loss you get. Tension gives you hair loss. Strangulation with sutures gives you hair loss. Everything gives you hair loss. Stress gives you hair loss. So you have to be very cautious about not causing more. Now you can see the incision goes back together. You can use staples for this, but if you want to be a fancy surgeon, I recommend using stitches. Patients do not like looking at staples. And if you think that staples and sutures heal exactly the same, it's because you suture the same as staples. It is not because they actually heal the same. There are minor differences. And if you're very, very neurotic, you will see those differences. If you're not neurotic, there's no difference. Now we're going to throw something called a horn suture. As the endoscopic lift heals, it tends to push back forward and bunch, and you get swelling behind the incision because the whole scalp was loosened up. So you want to keep it back here just for a couple of days. So what you do is you get a 3/0 nylon, you curve your stitch, you try to remember where the last point was of the muscle, which was over here. You pull everything back, and you want to just lasso straight through that muscle and up back through the skin. And find your tip right there. And you can see it's locked into the muscle, and you just tie it down. That'll prevent it. The other option is as you're closing one of those sutures internally, you can grab the posterior flap of the SMAS and tack that down, and that'll help prevent it by compression. But this is an easy way to do it. You take this out at about 3 days. And now we can get this little hair loop up out of the way. So we don't use braiding, as you see. Braiding is a waste of time. You just get a piece of autoclave tape. And as you tape the hair back, you can tape the hair in front of it out of the way. Now we go to the other side. Now we're going to mark this side. Hold that over there. So as you see, we're not going to pick the vectors ourselves. We're going to move it around and watch to see where the scalp wants to go. 3 vectors of brow aging. 1, 2, 3 in those directions. Superior temporal line, temporal region, medial brow. And they all pull back across in this direction, which is why we have a curvilinear incision like this, because we are fighting like that. So we're pulling this way, and that way. So imagine our arc of brow is this. Our incision is the opposite direction, curvilinear. The medial portion over here along the superior temporal line is going to be our medial pull. You can see if I pull this way, there's bunching over there and pressure. If I pull this way, it doesn't go very far, bunching and pressure. If I pull this way, it moves the most with the least amount of pressure. That is where we're going, right here. That's your vector. So here we go and pull this up, and you can see it. This way there's bunching, that way there's bunching. Here, there's no bunching. That's your vector. So here we go. Over here laterally, we're high up enough that we can just touch it into that muscle, or we can throw a third one. Let's just throw it in the muscle right there. Okay, fantastic. Now we're going to grab our piezo. You can do it with a piezo, or you can do it with a 1.5 millimeter striker drill. With a piezo, you just have to suction, and you can see it just takes a minute to insert, and you want to just vibrate around. Not too much pressure when you use a piezo. You just let it vibrate the bone, and it'll open it up. Just like that. Not the end of the world if you burn the bone a little bit. We're just throwing sutures. There we go, that's that. Now we're going to come across the back side over here, pull a little bit more, and we're going to line it up just to get into the same hole over there. Boom. Now we're connected. So it's a lot easier to connect with a piezo because of the angle and because of the thin tip. So I love using this. The drill is faster, but it catches hair sometimes. And I always tell people the worst thing you can do, and they're always like, get into the brain. And I'm like, no, the worst thing you do is catch hair. And you give someone a bald spot, and that is a terrible stylistic point. Just horrible. There we go. We're all connected there. So it's not as impressive in terms of timing. It takes a little bit longer. Now again, we're going through a fusion line section. And the fusion lines love to bleed, so we know it's going to bleed through a fusion line. And we just hope it doesn't, then you're like impressed. But it always bleeds through a fusion line. There we go. Or a suture line. And then we're going to come through here, match it up, usually 45 degrees. As soon as you see it go through, you can see the water passing through the other side, which is the really cool thing about the piezo. It just lines right up. The only not cool thing is the high frequency hearing loss that you will sustain because of the vibration of the instrument. It is what it is. This is how rock stars feel. Okay, let's get a stitch. So you always want to angle your stitch just a tiny bit. If you had a smaller stitch, it would be better. I don't know if they make a smaller suture for a 2O PDS. The answer is no. There we go. Just push it through. And voila. Straighten out your needle so you don't snag yourself. You push through. Boom. There you go. Push it all the way through. And we're nicely suspended over there to bone. Laterally, just like the other side, we will grab the muscle. And you want to do a figure of 8 suture. So you pass 4 and aft. And that's it. So we have our suspension points, and now we need a brown, please. And to find the vector of lifting again, someone's going to hold your stitch on one side as you can now rotate and find your vector. So you pull up this way and you see that's where it wants to go. I'm going to grab this temporoparietal fascia all the way down here. If you grab dermis or you grab too much temporoparietal fascia, you will cause hair loss. The biggest hair loss you can get is trying to do a distal grab, and you really take a big bite of TP fascia distally. You get massive compression and ischemia with that, and that's when you really lose hair. Here we go again, following the vector. We'll stay in the middle here. We see where it wants to go. It wants to go right there. It's going actually more vertical on our temporal side than on the other side. That's your TP fascia. It's very strong. You don't need to mattress it. Now we get towards the medial portion, which sometimes requires doing a mattress suture so it doesn't tear in case you're in frontalis. And what we want to do is just feel for it. It wants to go right here. And we're going to feel in there. And it's pretty strong. I think we're going to be fine. But you can see there's muscle and fascia, so it overlaps at that point. There's no really defined border where the muscle stops. It usually intertwines into the fascia and then decussates along the conjoint tendon. Here again we throw a single knot and that's it. We are suspended. It does not take more than that. The key to this stuff is understanding also what a brow lift looks like. A brow lift does not look like you lifted somebody massively. That's a surprised look. That's disgusting. A brow lift looks like a brow that's in a brighter position and a more relaxed position. So their disposition changes and the patient looks happier because the brow is more relaxed. That's a brow lift. Most people don't know that, and the surgeons attribute their failures to underlifting, which is not the case. It is incorrect vectorial lifting the large majority of the times that I've seen it. And even when they think it's successful, it's also a failure because they make the patient look stark, angry, inquisitive, or surprised because they lift in the vector of frontalis pull, which is the vector of all those emotions, which you do not want in a static face. So here again we pull. You always want to watch out on this medial one so you don't tear the frontalis muscle in case you're in the frontalis. And we pull down, try not to get hair in the incision. Bad stylistically because they get ingrown and they spit them out. And it's not good for healing. You get hair loss. Now we're just going to stitch everything back together. Put this fascia back inside. There you go. Okay, let's get a 5/0 nylon. You can see the incision closes up automatically. There's no dog ears on either side. The brow is in the appropriate position. The superior temporal line goes back to where it was. If you are misaligned along that marking that you made, you've pulled them in the wrong direction. If you have a dog ear, you've pulled them in the wrong direction. Now we just close it up with a running locking 5/0 nylon suture. You can close this with glue if you want. You can close it with staples if you want. However, my patients are a little fancy and they like to have pretty little closures. Now we're doing the horn suture on this side. Again, when you do endoscopic lifting, the scalp tends to push forward. You want to pull it back, keep it there. This is sort of a gliding type of thing. And you're tacking to the deep temporal fascia just to make sure it doesn't push back forward. I do not believe so much in the gliding brow lifts for aesthetic surgery because, number one, you're delaminating the skin, which I don't like to do. And you have to design the brow lift, which I don't know how you can design a brow lift if you don't know how it aged. You got to read some articles and figure some things out versus just doing this, it resets it. Now we're doing the upper blepharoplasty. In this patient, it's very straightforward. She doesn't have much hollowing other than in the infrabrow, which we already corrected. She doesn't have ptosis, doesn't have lacrimal gland ptosis. So there's nothing to correct there. She doesn't have a super hollow over there where you'd want to do fat repositioning. And then if you look at the brow height relative to the incision, it's paralleling. And if it parallels, that means that your lateral incision is also fine. Whereas if there's a discrepancy from medial to lateral and the lateral looks longer, then you have to raise the level of your incision or cut away more skin. But in most patients, it's raising the level of the incision, and you do that with the periorbitopexy, which we do not need to do on her. Now we're going to do a very straightforward upper blepharoplasty. So here we are making an incision across our lower marking, and you just want to be very, very delicate with your hand so you don't cause bleeding as you go through orbicularis. You always want to come to a sharp apex. The sharp apex will ensure that it closes easily and you don't get hypertrophy on the medial eyelid. And you just compress against the eye to get some counter tension, which helps your incision go a little bit more easily and stay in the right line. Now, the upper blepharoplasty can be super simple and straightforward, or you can do 20 things. You just have to have the ability to see everything. Now, I use a 15-blade scalpel to do the excision of skin, and if you see, there's a little greasy alveolar layer here, which is part of the superficial musculoponeurotic system, and that is a hydratatory part of it. So if you put hyaluronidase in here, the orbicularis is going to be sticking to the dermis, which you do not want. So it's better not to put hyaluronidase, better to use a 15-blade rather than cautery because you can see all the sebaceous glands. There's two types of milia that form when you do upper blepharoplasty. One type is from entrapment, and that's because these glands which are here stay on the muscle, and when you close the incision, you've enclosed the skin over the muscle and into the incision, so it entraps. The other is from inflammation. And if you cause inflammation in the upper lid, the other glands not even involved in the incision can become blocked up, and those get turned into milia. So one way to avoid that is just by using a 15 blade, and that gets rid of the entrapment part of it. And to diminish your risk of the inflammation, you want to use a non-inflammatory, non-absorbable suture, either a Prolene or a nylon. I prefer a nylon. So here you want to perform spot cautery. You don't want to do too much cautery because you cause fibrosis of the upper lid and poorer function. So you use a bipolar cautery on a 18 joule setting and come across and just spot cauterize anything that's bleeding. Some people believe in cicatrization or forming and deepening of creases by doing cauterization. I don't believe that's reality. I think it's largely imaginative. It confuses people because they see it contracting in front of their eyes. However, all they're really doing is vaporizing tissue and evaporating it. Now, you can deepen a crease by keeping the cautery there for a long time because you're going to melt any kind of tissue and fat behind it and fibrose it. So that can work, but what most people do that they think is deepening the crease or cicatrization is not really happening. It's just what they see in front of their eyes. It'd be like believing what David Copperfield and David Blaine do is actually happening. It's a little bit of trickery. Now we take a look at the muscle. We spot cauterized it. Medially, it's never a bad idea to take a look at the musculature. You can open up through the septum there with no problem. Levator exists in the central portion, not in the medial, not in the lateral. So you come and you elevate under the muscle, don't stretch the skin, and you want to do a little bit of a spread right in there, and you push on the eye, and you can see the nasal fat pad as it comes outwards. So you want to push on that with one finger, and the other finger you can grab it, you release it. If the patient starts to you can hear their heart rate start to drop, let go of it. The other tip for this is if you're going to release it to reposition, make sure you take advantage of the two heads of it. There's a medial head and a lateral head that come around the trochlea. If not, don't worry about that. Now, the other thing to watch out for is when you pull inferiorly towards the feet, there's going to be a vessel up here above the trochlea. If you hit that vessel, you can cause a retroorbital hematoma. You can free graft this if you want, but we already fat grafted, so we don't need it, but you can stitch it in. Now, since we're going to do a little bit of a skin excision on the lower eyelid, which I do not typically perform, but I will do today, you want to do a little bit of a lateral canthal support, and that could be from a retinacular suspension, which is what I'm going to do for her, or a full canthopexy. I don't like to do complete canthopexy unless necessary, because if you release someone's canthus, there's no way that your little puny stitch is going to ever replace the strength of that canthus. You want to pull upwards, you can release up, and then we're going to release down around above the periosteum and going under the retinaculum, and we're down into the cheek over here. So the retinaculum is right here. You can see it if you click, boom, click, click, your finger, it gets jammed right here. That's your lateral retinaculum, and that's what we're going to suspend upwards. I did not release the canthus. She does not need any kind of canthoplasty. She has a perfect insertion. So now we're going to close this. Give me a 6/0 nylon. And then we're going to need a 5/0 Vicryl for the retinacular suspension times 2. When we do a canthopexy, I use a 5/0 PDS. When we do retinacular suspension, I use 5/0 Vicryl. Here, I'm just realigning the middle of the eyelid incision. Few things to note. Number one, I do not do muscle excision unless it's for a very specific reason, like somebody just has a 20 millimeter skin excision and tons of muscle that folds onto itself. Number two thing is I always want muscle to close under the eyelid incision, or else it changes the color. It will turn white. Here immediately you can see I throw an interrupted suture into the apex, make a nice sharp apex. One way you'll avoid hypertrophy. Some people get confused in the first few months. They think they're getting hypertrophy of the incision, but it's really just sebaceous hypertrophy because the sebaceous glands get thickened up. And that goes away usually by 4 months. So I throw 2 interrupted sutures here. Then I close the remainder of the incision with a running locking suture. If I open the septum anywhere, I close the septum back up to make sure you don't get any kind of changes in anatomy or coloration. Here now you can start running it, and you want to take small bites. That's the other thing to note, is that thin skin cannot be everted. Thin skin like this heals very, very well and just needs to be approximated. If you try to take bigger bites in a running stitch, or if you do a running subcuticular and you get some overlap, you will cause inversion of the incision, and inversion of the incision is the #1 reason for wound dehiscence. Wound dehiscence does not happen if you do a tension-free closure with small bites and leave the stitches in for 5 or 6 days. You will not get wound dehiscence. You will not have the story that when my patient rubbed her eyes, she opened up her incision. That happens because people take too big of bites, or they use a running subcuticular suture and they don't approximate perfectly. If you approximate perfectly, this is thin skin. It starts growing over the stitches in like 3 days. Now if you invert, then you've approximated the outer portion of the epidermis. And if the outer portion of the epidermis approximates, it doesn't heal together because it's epidermis. So you have to approximate the dermis, and that's done by tiny, tiny little bites. And I'm not talking about the spacing between the stitches, I'm talking about the bites that you take with your needle from bottom to top. Now if I had opened the septum like I do in a fat repositioning, then in that situation I am going to grab the muscle on my closure, and I usually do a couple interrupted V stitches, inverted V sutures. Even though they're not really inverted, it's a real V. They call them inverted V for some reason. They're just V sutures. So you grab the skin, then you grab the muscle edge, and then the skin again, small bites. If you grab big bites on those, you're going to entrap muscle into your closure. Here you can see the closure. The first stitch of the running always goes next to the second stitch so you don't get bunching. We do 2 independent interrupteds here because you never want to run across a concavity. If you run across a concavity, it will cause bunching and hypertrophy. Laterally, same thing. Last stitch is next to second to last stitch so you don't bunch it. The stitching line looks nice. It looks pretty. Now, does that matter for closure? Maybe not, but patients like that. Now over here, we're going to look to see if we need to raise the incision. If we need to raise the incision, we would release upwards and do a periorbitopexy, where you grab the periorbita and you bring it up and you stitch it upwards to the periosteum. In this case, we do not need to do that because she's got a perfect height and symmetric height across the entire infrabrow. So what we're going to do is just give the lower lid some support because I know I'm about to do a lower eyelid skin excision. Lower eyelid skin excisions, I do not do commonly. I do it very uncommonly. So do we want to repeat that? I do not do lower eyelid skin excision commonly. Please understand this. This is like something that people don't get. I'm just showing it on this patient because she needs it. It is uncommon. I do lower eyelid skin excision. Most people have skin quality issues, and skin quality issues respond better to chemical peels. It's wrinkles, not excess. In this patient, she does have some excess. When you lift up, she was wrinkling up here, and she would stay wrinkled once you let it go. So what I do in those cases is I grab the retinaculum, give it a little bit of support, because anytime you elevate skin here, you're going to have a tendency to pull the eyelid down. So here I grab the retinaculum, which is right over here. It is very strong. And you want to take this vertically, not superolaterally. So this goes vertically, just on the front of the orbital rim, or just lateral to that. Let me get another 5-vicryl. And I like to throw 2 of these sutures. Now if I'm grabbing the canthus, fantastic. I can do that too. I just don't need to on this patient. I did not release around her canthus. I just released here, which is her lateral retinaculum, which is the ligamentous attachment, super strong ligamentous attachments that are lateral to the orbital rim. And again, you're not doing them superolateral. You're taking them just slightly vertical. And that's it. So we leave those there until we do the lower lid. Let's do the lower lid bleph now, please. You want to leave that loose just so you can get in there. Now, when we're doing the lower lid bleph, you want to make sure that you don't hit the eyelashes or the follicles. So you want to make small movements here. Control your cuts. Don't hit the eyelashes. Don't hit the follicles. And don't go too far down. When you go too far down, it looks terrible. So you want to stay right along there. And then you come into this downward turn. And now we're going to just do some elevation of skin. I'm going to take her slightly more medially. The easiest place to start dissection is here laterally because there's a little bit of SMAS that exists in this lateral portion. And you can actually just get into that plane very, very easily, just like that. As you get medial, it gets thinner. There's no more hydratoroid layer there, and this skin is just stuck to the orbicularis. So over here, that's the easiest place to begin. And then you want to just have very gentle grabs with your other hand. Stay parallel under the skin so you don't damage muscle. Now, there's always a question of skin muscle versus skin versus skin pinch. Now, skin pinch is a vertical movement, and the skin on the eyelid, I promise you, does not age vertically. So automatically I disagree with skin pinch. It's in the vertical vector, and I know it looks good when you do it, but what you're not noticing is the excess on the lateral portions that you leave behind, which means you've created tension, which means you're more vulnerable to eyelid shape changes that occur down the line. So to minimize the risk of that happening, you have to really stay under the skin here. Do not denervate the pretarsal orbicularis, which is your most important part of your orbicularis. Tiny, tiny moves, and you can see through the skin there, which means we have no muscle on it. So that's great. Now I'm going to come again from lateral to medial, just like I did. That's the easiest way to do it. And you can pull towards yourself, tenting like this, pull it back, and then you can dissect the muscle away from the skin without causing little buttonholes in the skin, just by pulling towards yourself. And you don't want to do a huge dissection. You want to do just these tiny little moves. Be very delicate with the left hand. It does tear sometimes. And there we go. So we've elevated just enough. Don't need to go more than that. And then you can see where the excess is automatically as you just do that. And if you see the excess as I elevated, it does go automatically superolaterally. Most of the skin excess is coming out over here, not under the eyelid skin, and it's going against that vector. So the vector of aging is here. It medializes. When you release the skin, it automatically wants to come out over here, which is not vertical. This is superolateral direction. You can see all that excess. And that's for minimal elevation. I don't want the skin tight. I want it relaxed. I don't care to get rid of every wrinkle. I'll get rid of some of them, call it a day. I'd rather have a couple wrinkles in good eyelid shape than no wrinkles and a rounded eye. It's not a good look. So here we're going to keep pushing up against the eyelid to make sure we're not taking any extra skin. So I keep pushing the eyelid back up, and now I'm just going to march along and tailor and trim only as needed, leaving a little bit of redundancy so you never pull on the eyelid. The eyelid is very sensitive, very delicate, not very strong. And if you pull on it, it will change shape over the following 5 years, 6 years. It'll just keep getting slowly worse over time. So here I'm just taking my time, coming across, and then you want to straighten it out, get away from the eyelashes, and trim only what's needed over there. And that's it. Now we can double check. No scalloping. Everything else is perfect. 6/0 nylon. Perfect. So you can see it realigns. You always want to put the apex together first, which is right over here. Sorry, the peak of the incision. You put that together first, and then we're going to realign the lateral apex and bring it inwards. Now you want to do all this before closing your canthopexy or your retinacular suspension, because otherwise it gets very difficult to stitch. So the reason people scar out here, number one is tension. Number two, loss of volume underneath because they cut muscle on the side. Number three, color change. They don't have the muscle under the skin. Those are the top reasons. The other reason, which also happens, is dog ears, because they close in the wrong direction or they left excess somewhere. So they close from medial to lateral instead of lateral inwards and medial outwards from apex to the middle. And you can just prevent the scar easily by doing those things. So here we are starting at the medial apex, and we're going to run it outwards. When you're on this side, your first stitch goes from bottom up, so it pulls the tail away from your eye. When you're going from the other side, it may do the opposite and pull the stitch into the eye. So always make sure that your first stitch goes from the bottom of the incision to the top, and it will pull the tail of your stitch away from the eye so it doesn't irritate the patient. And this is when you're doing skin excision. However, I will repeat, I rarely do skin excision. It is very rare that I would do that. Most of my patients, if we do lower blepharoplasty, get a touch of fat grafting with transconjunctival fat repositioning, which effaces the insertion of the septum. And then I do a chemical peel, TCA 35%, or sometimes a CO2 laser in order to get the skin quality improvements, because most people do not have true skin excess, or they have an eyelid that's too delicate to sustain injury from doing these lower lid blepharoplasty skin excisions. If I'm doing a combination of skin excision with fat repositioning, I'm still doing transconjunctival and then lifting this limited skin flap. Fantastic. Only use the tip. Now we are finishing the retinacular suspension, so you just pull your 5/0 vicryl. And you want to throw a surgeon's knot because it's a vicryl. Try not to capture the orbicularis. And you just tie it down sequentially just like that, scissor to me. And you can see that it tightens up the entire lateral eye just like you did a lateral canthopexy. However, I did not disrupt the canthus, and that is super important. It is never a good idea to disrupt a healthy canthus. Your stitch will never replace the strength of a healthy canthus. And it's important to realize these things before tampering with someone's face. Some things you cannot recreate. The canthal attachment is one of those things, which is why you never want to do one of those weird cat eye surgeries or fox eye surgeries or whatever they call them, where you do a canthoplasty on a young, healthy person. Terrible idea. 6/0 nylon. Here you can see on the lateral portion, we've opened the septum, meaning we've opened the orbicularis, and we have to put it back together in order to prevent atrophy of the incision and in order to prevent color change. So again, we start laterally on the apex here. Do a closure. Let me get a 6/0 nylon, please. Here you can see I'm going to align it myself. I pull the apex away. I can grab now the middle of the incision. Since I've closed the apex, small bite. Grab your muscle, small bite. Muscle again, small bite. This is a V-stitch or it's not a U-stitch. A U-stitch is a horizontal mattress. This is a V-stitch. And you come and close it just like that. Now your muscle's reapproximated, and these sutures, just like all the rest, come out at day 5 or day 6. And if you do things like this, you will not get a wound dehiscence. And you will not get discoloration of your incision unless they have some pigmentary issues medially on the incision. And that's it. Now we're going to begin the upper blepharoplasty on the opposite side. Again, a 12 millimeter marking, and you can see it's really where the crepey skin of the eye is. Below it's going to be your pretarsal skin, and that's above is your supratarsal crease. So this is all pretarsal skin. This is brow skin, and the brow skin is smoother. The pretarsal skin is more vascular, and then there's a color change and a granularity change as you get to the sebaceous portion, which is going to be your upper eyelid skin. Medially, you go into a sharp apex, and the key there is avoiding any kind of effacement of your epicanthal fold if you have one. She does not have an epicanthal fold, so we extend it normally into the apex where it wants to go. Now we're going to stretch across, give some distension, and allows you to follow the line of the incision a little more accurately and precisely. On occasion, you'll see that you need to take a touch more skin laterally. It's pretty uncommon. If you do and you see any excess on closure, you could just trim it with a scissor. Now we're pulling, stretching, keeping everything taut as we go. Fantastic. Here, laterally, we're excising the extra skin by pulling up on it. So your left hand is doing most of the work. Again, we're using a 15-blade scalpel to avoid any kind of milia staying behind. All right. So we progress forward by giving ourselves tension, counter tension. Left hand is doing most of the work over here. And you can see we're excising all of these sebaceous glands along with the skin, not leaving any to be entrapped. And then we're going to use the 6/0 nylon for our closure to avoid inflammatory healing as much as possible. Here you can see we're going to do spot cautery. Spot cautery meaning we want to avoid cauterizing the entire muscle. You want to keep it functional and not fibrotic. You'll see things shrink. That doesn't mean anything in terms of tightening. It doesn't mean anything for cicatrization or anything like that. It's just you're evaporating fluid, especially the tumescent fluid you just injected in there is all evaporating out when you pass current through it. It's a very ionic environment. Medially and laterally, you can cauterize and get through the septum without hitting the levator. Centrally, you have to open it much more carefully. So here we make our little hole right over there, parallel to the muscle fibers so you don't damage the muscle fibers. Here again, parallel to the muscle fibers so you don't damage the nerve or muscle fibers beneath that. And voila. Now we're going to come in over here, spread, push, spread, push, spread, push, and you can find the fat pad just like that. This is your nasal fat pad. Your nasal fat pad should be coming vertically out of the face. If anything's pushing out from lateral to medial, that is your preaponeurotic or your central fat pad. If your heart rate ever starts to drop, not yours, the patient's, you want to let go of that fat pad. She doesn't have much centrally to worry about, so we're just doing the most basic trim. You can see there's a medial and lateral pedicle or heads to this. And that's it. Come out. Scissor. Now we're going to open up for our lateral retinacular suspension. If I'm doing a periorbital, I would go superior and inferior. But in this case, we're just going inferiorly around the canthus, under the retinaculum. We've released that all. Boom. Canthus is untouched still, but these are lateral canthal support. So you do have to resuspend them now. We're going to put in a 5/0 vicryl, and the reason I'm doing this, so here's your retinaculum is from the lateral canthus. When you look outwards, there's a ligamentous band over here and right above it, and if you were to put your instrument in there, you can flick it. You see that? You flick right, 1, 2, boom, right there. That's your lateral retinaculum, is this, very strong. And you want to grab it just lateral to the canthus over here. You can see how strong that is. And you want to elevate that vertically, not horizontally or superior laterally. So you find the orbital rim and you stay just lateral to the orbital rim. Very straightforward, not very complicated. And this is a much better suspension than orbicularis hitch or orbicularis suspensions that you do. This is stronger and more natural because the retinaculum naturally attaches to the periosteum, whereas orbicularis does not naturally attach to the periosteum. And this is the ligamentous extension above the periosteum that exists between the upper and lower orbicularis. That's what the retinaculum over there is. So we leave that hanging. Now we're going to go to a 15 blade. We're going to do our skin excision, which again, I will say, I do not do skin excision very commonly. This is something I do twice a year, 3 times a year, very rarely for patients who need skin excision, which is rare. Most people get a transconjunctival fat repositioning with a chemical peel, and that's about it. Every once in a while, I will do a subciliary skin excision. When I do it like this. So you want to just come right under the lash line, small marching movements as you get under the eyelashes. Keep moving the eyelashes up. Try not to hit the follicles of the eyelashes. And don't go too far down. People make their incisions so far down when they do this. It's terrible. So just right over there, nice and thin. Now the best place to start is here laterally. Laterally is the best place to start because you have a little bit of SMAS there, which is the most microscopic layer of SMAS, but you do have some there. And you have to come right under here, just do little spreads, and it opens right up for you. It is an easy plane to enter into and to dissect in, just like that. Always go lateral to medial, tent it out for yourself, just like this. And when you get under the skin there, make sure you're not trimming muscle. So you want to leave the muscle as unmolested as possible. So you come here, really stick under that muscle, or over that muscle right there. Don't hit any hair follicles. Bad style point. Don't want to have to sacrifice any follicles. And you just stay right under the skin. So I'm tenting out with this finger, pulling up with this finger, and you get some transillumination right there. And you can use that to make sure you stay in the right plane, as well as small little movements. Over here medially, you want to continue right under the skin. So you want to see your scissor tips through the skin. It's pretty translucent skin, so it's not hard to do. If you don't see your scissor tips, it means you're too deep and you're under the muscle. And that's about it. So we're almost done. Just gonna make sure I did a nice even elevation everywhere, just so I don't affect muscle movement. And that's it. Now, when we look at the vector of excision, you'll see when you just touch it, it goes superolaterally. Most people age in this direction because the medial canthus is anchored, and when you blink, that's the stronger part of your blink. You can see when you release the skin off of it, it goes this way. So that's where your excess is. We want to make sure the eyelid's in a high position right there. Now I'm going to cut down to the apex, which is right there. I just took a peek at it. Looks like it's right there. And then we're going to come across with tapering skin excision as we go lateral. And that's that. Nope, always wipe upwards. So we're always wiping upwards to keep the skin in the right spot. Everybody is different. So it's not a good idea to have a routine amount of skin removal that you do for patients. So here, you can mark it with the little blood that you have on your scissor, and then you can come across and see where to cut it. So that's a little easy way to do it without using a marking pen. So I'll make sure I don't have any tension, no excess. There's a little excess still. I would rather have excess than not enough. So what happens if you're coming across this and you accidentally cut too much? You don't cut it off and try to release more. You just stitch it back together, and it goes back together pretty nicely as a skin graft, and it heals fine. So just put it back together if that ever happens. So there's no tension on this closure. Don't move because we want to have this aligned perfectly into this little apex over here. Everybody whispers during this part, and fantastic. No tension on this. And we've supported it laterally, and we're doing a mid-face support with lifting, and we did a preload support with brow lifting. So the chance that this is going to cause a problem, it's not zero, but it's almost zero. Again, here we're closing from the apex inwards, always a good idea. Don't form a dog ear if a dog ear doesn't need to exist. We love dogs, not their ears. Ask a Doberman. I'll be so happy if this stuff actually ends up in the video. Over here, we're going to close the medial portion of the eyelid incision. Because I'm standing on the left side of the patient, you'll see that the tail of my stitch is going to end up upwards, and this can scratch the patient's eye. So it is a beneficial technique to reverse your first stitch, have it go from bottom up. And then after that, you can either follow it bottom up or you can go top down. But you can see what happens to the tail of the stitch here. It pulls downwards. So that keeps it away from the patient's eye, and they don't call complaining in the middle of the night that their surgeon is terrible and hates them. And makes the things easier. And then now you can just follow with a running locking suture. Easy peasy, lemon squeezy. Okay. Can I get a spray? What's crazy is sometimes when you set their hyoid in a higher position, they start to breathe better. Don't know why. I figure it would be more anterior, it helps them, but So here we're closing the muscle again. Now we're performing the submental work, which is platysmoplasty and any kind of deep neck work that needs to be done. I'm going to make the incision a little longer than we usually do just for purposes of the video to be able to see everything. It'll heal fine, so I'm not too concerned about that. Usually it's about a 2 centimeter incision. Right now we're making it about 3. Let's get a double prong over here. The key to submental work is first realizing that when you lay somebody down on their back, they have a tendency for the submental contents laterally, meaning the submandibular glands, to tuck back upwards a little bit more than when they're upright. Let's put on 25, please. So you don't want to melt fat so much there. I just get through it initially with that, and then we want to put tips down and then continue our opening in the submental area over the platysma. Just want to release laterally, going that way along the jawline, and you don't really need to open the mandibular ligaments if you've fat grafted them for the most part, which is great because then you avoid the ischemia that comes with mandibular ligament release. And here you want to keep a nice thick flap as you come in, coming directly over the muscle and then extending laterally. Perfect. So here you want to release on both sides. Keeping your finger on the back of the flap so you can try to maintain adequate depth over here and keep fat on the skin. So if you don't keep fat on the skin, not only do you increase the amount of banding that you have, but you also develop issues with coloration. The skin looks darker over time. And these are the 2 reasons that I don't perform much liposuction. I do liposuction maybe twice a year out of 300 or so facelifts, and I do chin implants also about twice a year out of 300 or so facelifts. They are not necessary if you are better or more adept at lifting. Once we do that, we can finish our dissection using a lighted Alfric retractor and just spreading across very quickly and easily. So over here, we always want to look at the platysma, grab the lateral, pull it medially, and you'll see when you do that on her, she doesn't have much give. So what we want to do is just go straight down the midline. So I'm going to incise straight down the midline. I'm not going to excise any kind of intraplatysmal fascia on this patient until I see, maybe if I do a volume reduction, then she'll have a little bit more redundancy. But for now, that's all I want to do. And here, you can see we're going to elevate towards one side, then the other. Right here, we're going to elevate under platysma. And we're going to elevate directly over the digastric muscle, pushing away this lymph node. And you could just bluntly dissect with your needle tip electrocautery. We want to come and release all the way to the lateral hyoid. So here we're elevating over the digastric to its lateral insertion around the hyoid. And then once we get far enough, you can bluntly go with a scissor and just open it up like this. And go laterally, and you can analyze to see if there's a submandibular gland there. And here you can see her submandibular gland opens up, and it's a little inferior to the hyoid. Now we do have to do some perihyoid slimming on her, so I'm going to reduce that gland a bit. Now before reducing the gland, we're going to inject it with a little numbing medicine. That'll help both with decreasing the stimulation and with bleeding. So we leave that. Now we're going to go to the other side. So here we are elevating right underneath the platysma. And you can see no smoke accumulates because we have this lighted Alfric retractor, which has a suction on it from Hayden Medical, who made that for us. And here we go extending over the muscle. And then again, once you get past the vascular portion of the connections, you can just do blunt spreading to separate away this anterior digastric muscle from the platysma. And then inferiorly, if you want to do a little bit of elevation, you can continue with the cautery, and there are little ligamentous attachments along the cervical mastoid accessory, well, the suspension ligaments over there. And now we want to open up to see if there's a gland over here. So you just spread bluntly over there, and the gland, as you can see, again, is inferior to the hyoid and ptotic. Now, gland ptosis can't always be fixed with gland elevation. In these cases where it's broad and low, even if you were to elevate really, really high, you would still have fullness around the hyoid laterally. So it is important to reduce these patients. Now, only 10% of patients actually need any kind of gland reduction. The other 90% do not need it. I do it more often now than I used to, just because I'm in an experimental phase in my life. Okay, let's go back to the other side. So here, in order to get under the platysma, here's your platysmal flap. We're going to elevate it to the skin. And I'm just passing this PDS suture through it to give me a little bit of suspension to get it out of the way. It's just a nice way to open it up as you're going after the gland or other submental contents. Now, anytime you do any kind of medial reduction of volume, that dictates that you do more lateral reduction of volume. So here we have the submandibular gland right over here. Now, I do want to do some sort of reduction here in the digastric region. So I'm going to try to make the neck less obtuse and more acute. So I'm just going to reduce some of the paramedian fat, not central, and some of the digastric. Now, the fat you can just excise with some lymphoid tissue right there. And then for the remainder of the digastric, you want to use your bipolar. And you can just pull it up, grab it, and do a trim of the ventral surface of the digastric muscle. Just like that. Watch your tip as you come out so you don't burn anything. And we can just trim it with a scissor all the way to the lateral fascial sling. If you follow it laterally, you'll see that you do end up at the anterior medial border of that submandibular gland, which is now slightly better exposed. Right there. So the first thing you want to go after is that part of the submandibular gland, which is the medial anterior border, right here. Here you can see we're going to release around the gland. Now, the key to gland reduction is releasing it circumferentially before you cut into any parenchyma. If you start cutting into parenchyma, you're just going to get bleeding. So what you want to do is grab it very gently. Do not grab it firmly. I'm using a tooth debaki. And you just want to slowly push away the capsular attachments circumferentially on all sides. Keep pushing it away, before you cut through any parenchyma. If you start cutting through parenchyma, it's going to bleed. If you pull too hard on it and then you let go, it's going to bleed. So the key is grab it gently, circumferentially release it. Now you can come in with your bipolar forceps and go through the parenchymal lobes rather than cutting into the parenchyma. You can use other instruments for this as well, but I find that this is a little more precise, and with the bipolar you can actually go through the parenchymal lobes rather than directly through the parenchyma, which means that you're going to cause a little less injury to open glands. Here you can see there's these vertical bands. These vertical bands are either ducts or arteries. So you want to vertically go across them, grab them from the distal portion, and then release them proximally. Just like that as you march your way through in between the parenchymal lobes of the gland. Now, because I'm not grabbing very hard, I can release as many times as I want and keep kind of marching my way through. Now this patient, this part's coming out easily. There's a little bit left behind. So I'm just going to reduce it and move on. Usually you try to remove as much en bloc as possible. Now if you ever get a bleeder, realize that all bleeders are arterial. So don't freak out. You just want to inject it with local anesthesia into the gland area, pack it, and don't touch it for about 10 minutes and it will slow down, and then go back usually with an extra set of hands to help you out. These bands are vessels and ducts. So you want to go vertically across it. There are no ligaments within the gland, so if you ever feel resistance, you are coming across a duct or an artery. And you don't need to Botox the gland if you do it the way that I do it. If you do it a different way, you might have to. But if you do it this way, which is just staying inferior to the hyoid, and you go across these ductules one by one, and then you do a really nice lift laterally that compresses everything, you don't need to put a drain, and you don't need to place Botox. Now, if you do it differently, method's different, then yes, maybe those things will be required. However, I have not done drains nor Botox, and I'm completely fine. So this last portion that I'm going after is the most delicate because it's the most proximal in terms of floor of the mouth. So I'm a little more careful with that. Now you can see the capsule is nice and hollow there, created some dead space. We're going to do some irrigation to cool off the nerves. If the nerves heat up, that can increase the refractory period for the action potential of the nerves. And if that progressively gets worse, you're going to cause paresis from fatigue. That's what you see if you do nerve monitoring. Now we're on the right side, we're going to do a suspension of the platysma to get it out of the way. So we're just suspending it up to the skin over here, and that'll give us a little bit better access and visualization. Here you see that the digastric up here is not bowing or bulging. However, down here it's a little too low and obtuse. So your options for this are either to release the insertion a little bit lower and allow it to come up higher on the fascial sling, or you can reduce it a little bit. I'm just going to reduce it at this angle, going horizontal to where I want the submentum to be, and that'll allow me to trim it. Now every time you do any kind of anterior digastric reduction, you will be causing automatically myositis for the following month or so, and that's increased submental edema that occurs because of that. Now we have direct access to the gland. Now if you're ever going to reduce digastric, realize that you have committed to automatically reducing the gland laterally. You have to, because you've created a relative ptosis. So you can take this gland and you slowly start releasing it from the surrounding structures, which is the surrounding capsule. And you do that with monopolar electrocautery and just pushing the capsule away as you go. Medially and inferiorly are the easiest places to get it going. So again, here the key is to circumferentially release around the gland rather than cutting through the parenchyma yet. And you just want to release all sides of it, push the capsule away. The gland fairly adherent to the surrounding structure sometimes, like in her case, and you just pull gently, make sure you don't pull hard. If you pull hard, it's not meant to happen. So there, we've released circumferentially around the gland. Now we can start to truncate it across the base. So we come straight across the base over here in a more controlled fashion. And this is how you largely avoid bleeding and other problems. So the issues that you could have are bleeding or sialoma. When you go across it bit by bit like this and you identify all the bridging vessels that are going through the gland, you're closing off the vessels one by one. I think one of the problems people have is trying to bite too much, and they come across the parenchyma and the gland, and then they hope that the little vessels don't leak. Whereas this way you can go directly through the lobes, find the vessels one by one, and just like that, like I just did, you close them off with your bipolar cautery. And I've never used Botox, I've never used a drain, and I've never had a sialoma, and I've done a lot of these. Now it's going to happen at some point, but it hasn't happened yet. But I've done a lot. So one by one I'm going through, trying to stick to the gland. If it ever gets too wet, I'm going to dry it off and make sure you're not getting heat dispersion of the surrounding areas. So she's got a very vascular gland, a lot of vessels I'm going through, more than most people. Most people you just go through in between the lobes, and there's a few vessels here and there. She's got a lot, so it's a little more cautery than we normally do. You just got to make sure you're not getting too much heat dispersion laterally. Here's another vessel. You can isolate them if you want and see them. They're right here. You just go up and down and then grab it and push it back. But it's much better to go in between the lobes of the parenchyma rather than trying to blast through parenchymal tissue. And here I'm closing another vessel. You can feel them and see them. Taking my time, And that's that. And you can see that the digastric is in a nice horizontal plane. It's flat. Our hyoid is right here. And you don't see any gland inferior to the hyoid anymore, which is how you want it to be. No gland inferior to that hyoid. So you just trim straight across it. Here you can see that we've cleared around the hyoid, right around there, circumferentially. It's slim. This is a tongue of tissue that was released, and I always leave it to make sure to see if I need it or not. If your larynx is more anteriorly projected than your hyoid, then you got to leave this tissue to cover the hyoid and cushion it. In her case, it's not. We can get rid of it. She doesn't need it. But always keep that little tongue of tissue so you can leave it in front of the hyoid if you need to soften that cervical mental angle. You don't want the cervical mental angle to be hollow. And now you can feel the hyoid all the way across. So pre-hyoid fasciotomy, you just pull up on the mid-hyoid fascia or the mid-cervical fascia and you incise directly across it. Now we're just going to perform a submental platysmoplasty. Not in the classic corset fashion, but just the submental plication. Here we have our two platysmal flaps, left side, right side over here. We want to pull it across midline, but not just pull it across, give it depth, just like that, because that depth will show you how much you need to have. So see here, I can actually reduce some of this now. Whereas beforehand I reduced nothing, I just cut in the midline. So I'm trimming the tiniest bit off the medial portion. The key is always do less than what you think. And you pull that across. Now it's perfect. Come straight across to midline. This one comes straight across to midline. Just going to trim the tiniest bit right there. You don't need to trim much. Now we're going to perform a platysmal plication to bring it to midline. First I throw one in front of the hyoid and I throw it interrupted, buried suture with a 3/0 nylon. You could use any suture for this, almost anything. It doesn't really matter. So you always want to throw this in front of the hyoid, not grabbing the hyoid fascia. If you grab the hyoid fascia, you will effectively tether the entire deep plane and you're going to obliterate that space, tether it, and you're going to alter their swallowing function because they'll have no glide plane anymore between the platysma, the hyoid, and the larynx. They're all going to move together. So not a good idea to do any kind of plication or tacking suture to the hyoid fascia or the submental fascia. It's unnatural, and it doesn't benefit you anyways. Your midline is always more retracted than lateral anyways, so you shouldn't do that. I'm going to do figure of 8 mattress sutures to close the remaining of the submental platysma because the submental platysma is a muscle and it's very weak. So we're going to come deep first, then go superficial to deep, then deep to superficial in a figure of 8 fashion since you can't bury a horizontal mattress, and then end up again superficial to deep where we started, and you close that off. That is your figure of 8 mattresses for the submentum, which will keep that weak platysma together. Here again, we start deep, going outwards. We're going to come across lower, superficial to deep, lower, deep to superficial, upper, superficial to deep, not grabbing any of the deep fascia, just closing the platysma to itself, which causes an automatic trapdoor effect in the midline, indenting the midline, which again tells you not to excise direct submental tissue. Everybody does that because it's easy, not because it's the right thing to do. You should leave submental volume as much as possible. I only excised paramedian on her, and she still had barely any volume left in the midline when I was done. Now, doing a submental platysmoplasty or submental plication does not restrict your vertical movement on the facelift very much. Once you go infrahyoid and prelaryngeal, then you're substantially limiting the vertical movement of the face because you have plicated and medialized the area of the platysma which is divergent, which falls away from each other. So when I close prehyoid on her, or prelaryngeal, if there's anything open, I do it with the smallest bite possible. I do not want to fixate her to the midline in the infrahyoid region, which would limit me from doing my facelift. Fantastic. Right now we're going to look at the height of the platysma to make sure it's long enough, and you do that by seeing if there's any tension in the platysma, which there's a little tiny bit. Then you put your finger in and you want to feel if there's a band in the midline, which on her there is because we shortened it. So what you have to do in that case is a little tiny myotomy, inferior and oblique. I like to do partial myotomies, and I do it inferior to the hyoid. If you do it at the level of the hyoid, the problem you're going to encounter is an indentation that happens later in the submentum, especially when they swallow. So now I did a partial myotomy there, and that helped let this part tuck up. Now there's no band in the midline anymore. Great. So that's that for the submental platysmoplasty. Come out, then we check again for mandibular ligaments to make sure we didn't medialize anything just by pulling up, and you see we didn't. So she's fine. We can tuck in a gauze here and then go to the facelift. Here we're starting this side of the facelift. You can start with whichever side you like. If you see, we've paralleled the incision with what we call the sailboat modification at the deep plane entry point. The classic deep plane entry point is here. All I do is parallel the incision, so when it comes up, the mass fits like a little puzzle piece, and you don't have any excess area that was skin dissected for no reason. If you follow this lateral line downwards and come back a little, then move forward, you'll see this is the lateral border of the platysma. As you get over the midpoint of the SCM, the platysma becomes non-adherent, where the external jugular vein comes up right over here. Your great auricular nerve runs right on the side of it or right above it. Usually it's right on the side of it. Right over here is your great auricular nerve. Platysma, even though in most textbooks it's depicted as spanning out over here, it does not do that. The platysma is adherent over here over the lateral parotid, which we call the cervical retaining ligaments, and then becomes non-adherent as it goes over the SCM, sternocleidomastoid, down over here where the EJ crosses underneath it. And it follows on the medial border or over the external jugular vein down into the neck. So the actual shape of the platysma is that. It goes down into here. It goes from medial down to the clavicular head. So this is the thinnest portion of the platysma down here. The broadest portion of the platysma is up over here. 10 blade. Here we're making an incision into the temporal tuft. You don't need to bevel. It doesn't make a big difference. If you do bevel, that's totally fine. You just want to leave the sideburn unmolested as much as possible. You come into that deep crease, make light incisions as you come around. We're going to come into the crease in front of the tragus, going down into that little helical root right over there. You want to make that a sharp turn. As you come around the earlobe, you have to decide if you want to shorten the earlobe at all in an anterior-posterior direction, and if you want to release it. If you want to release it, you start just brushing it. That way you don't damage any nerves, and you just kind of brush it downwards like that. We go into the postauricular sulcus, barely touching it, pulling forward, going across transversely, and then down into parallel the hairline as we go over there. We'll get a brown over here. In our root of dissection, typically you make a small incision and then you can start peeling it away. You can peel it off of the superficial temporal vessels, which are very superficial right there, and that way you don't get them to bleed. And as you go forward, you want to make sure you stay in the junction of the hypodermis and the SMAS. Most people have trouble telling the difference between the two, but I'll show you right now what the difference is between the two once we open it. And you can see here as you're elevating the skin. Now, if you look over at these fat cells here, they're small and granular. That is hypodermal fat. If you look at these fat cells over here, they're large and they're lobular. That is SMAS fat. So hypodermal fat is these little tiny granular cells. Over here is the SMAS fat. So what we want to do is be in between the two so you preserve that. Now you see a little bit of filler here. So she's got a little bit of gel filler here on the sides. Not sure why it's there in front of the ear, but it's there. And you want to go ahead and keep continuing your dissection in that hypodermal plane. Right over there, she's got a bunch of filler there on the side. Okay, now we're going to switch over to the bear claw retractor. We're going to retract towards ourselves, and that's probably why she's a little inflamed there, is that chronic filler that just sits there. And you want to come forward in a hypodermal plane, leaving the hypodermal fat intact. And you can see we just use a little retraction, counter retraction to stay in an even plane, small bites as we move forward, and then here along the line of the mandible. Relax. You don't need to really go above the line of the mandible. You just stay at the line of the mandible, connect into the neck over there. And now we're going to come over here and release around the temporal region and then around the eye, which Liz is going to protect with her other hand since we threw retinacular sutures over there. So this area you can transilluminate, or you can just look from the top here and you use your finger on the back side to help guide and gauge exactly where you're going and what depth you're at. As long as you have someone pulling against you, you're not going to buttonhole. If you don't, then yes, you can buttonhole. That's all your skin dissection. So we already finished the skin dissection, double prong brown 10. Over here you see we are going behind the ear, going to continue our skin elevation. Posteriorly, you just want to get right at the base of these follicles. Anything more than that's going to start bleeding. Now, anytime you elevate something with your left hand in an arc, you have to cut in the direction of that arc. So you have to look at the blade and follow it and make sure that you're following the direction of that arc. And that way you don't cause, again, any buttonholes or anything like that. And you have a nice even plane. As you get medial over here, you're going to be coming over some of the posterior auricular branches, which are deep to the hypodermal fat plane. Again, in that SMAS, which the SMAS over here is very thin. Once you get laterally, it dissipates. It doesn't really exist much anymore. So we're going to retract, pull up, pull down, and you see we're just going to do little tiny movements. Now, she's a little bloodier than most people, a little inflamed. The key thing here is you can always give TXA if you want. However, do not inject TXA with your solution on a facelift. It's okay with eyelids, it's okay with lip lifts. On a facelift, it's not okay. You have large flaps, and there have been several reports of major cytotoxic effects, including flap necrosis, ischemia, islands of ischemia, very strange things. So that's a very important thing to note, is do not put TXA into your solution for injection, even though you can give it IV. So right now we're going in the hypodermal plane again, marching forward. As you get down over here, you get closer to where the great auricular nerve becomes more superficial. And she's very dense and adherent down here. So we're just doing little snips and pushes as we get down. And then once we get to the preplatysmal plane, we can switch over to the blunt dissection. Here now we're going to go continue the dissection in the supraplatysmal plane. And our dissection usually stops halfway down the neck or just above the level of the thyroid cartilage. If you go beneath that, you're going to cause devascularization of this entire area over here. It is not necessary, and you can see by my results, even when I go here, I get massive improvements in skin quality all the way down to the bottom of the neck. Most of the improvements in skin quality in the neck do not come from you lifting as hard as you can. They come from creating contours. When you create contour and depth, this skin that now travels straight across in a blunt fashion is going to start traveling in a deeper fashion this way and then that way. And you've increased the amount of area that it has to drape across. So automatically, without skin excision, it ends up improving the skin quality. Now we're going into supraplatysmal plane. We're going to pull up with our retractor and push down. Pull up, push down, and we're pulling up and pushing down all the way across the neck to connect with our submental dissection all the way up to the jawline, and make sure we release inferior to that jawline all the way across and all the way to our incision. Inferiorly, we do not need to go lower than that halfway point, and that's it. So that's our dissection. You can see all the way through. If you look outside, we dissect it from here to here, which gives you an idea of how far you need to dissect. The less you do, the better. The less delamination, the better healing you're going to have, less risk you have. Now we're going to enter our deep plane entry point. Our deep plane entry point parallels the hairline. We're going to start at the lateral border of the platysma right here. We're going to do that just to show everything as we pull up. But you can see from here, the entire lateral border of the platysma is right here as it comes up onto the face. And you can see that fold exists up to there. And then the fold disappears, which means the platysma is gone at that point. Now, if we look at our external reference point, that is where I drew the platysma would end. And that's where you see it right over there. So you can actually see this physically in somebody. Most people just don't know how to look for it. And then we're going to continue that line around our deep plane entry point over in that direction. So we want to start our deep plane entry point by putting some pressure on the back over here. And we're going to incise just like this. And you can see how we're getting automatically at the lateral border of the platysma right over there, and then under the SMAS. So you just make little tiny incisions just like that, and then we're all the way through already. So now you can see the entire subplatysmal plane right there, which we're going to continue our dissection in. Now we're going to come up here and finish off this portion, which is our mid-face SMAS, to get underneath it. Now as you elevate, you can see here the SMAS is up there, and this will get you subsmas, subsmas, subsmas. You already see that. You bevel your knife upwards here. And the reason for that is the zygomaticus muscle is very superficial here. And then you go parallel like this. So you start in an upward direction, just like that, and then you go straight across, just like this. And now you've opened up over here, and we're going to continue over the zygomaticus musculature, which is right over there. You can see the lower zygomaticus and the upper as you get to orbic. Here we're going to go into the deep plane. You can see the parotid gland is here. So the parotid gland we're going to push down, and we're going to go over the fixed portion of the SMAS. As we push the parotid gland down, here you can see we are over the parotid gland, and that is the fixed portion of your SMAS, which if you continue inferiorly is called your cervical retaining ligament. Now if you get to the anterior part of the gland, you're going to notice we now open up into the premasseteric plane, which is your mobile glide plane between the platysma and the masseter, because the platysma and masseter are two separate muscles that do not function together. They function independently. So everything just opens up, and you stop your dissection right there at the facial artery. Now if we look inferiorly, we can dissect down into the neck, and we're going to release the lateral platysma as it comes over the tail of the parotid. And we need to do that by sticking our tips downwards and then dissecting back against the tail of the parotid in what we call the cervical retaining ligaments, right over here. So we dissect away as much as we can from this direction, and the rest we can do from lateral inwards. Now we're coming up on the midface, and you can see we're going to come right under the SMAS and dissect on top of the zygomaticus complex. And if you pull up and push down, you'll notice that we're going right over the zygomatic complex. And you want to just go in an inferomedial direction by marching forward. Now we're going to continue over the zygomaticus complex, which you can use the FAME technique with your finger. You can go through with scissors. I prefer scissors. Here you can see a small lymphatic channel. That's what they look like. This is what gets disrupted in the midface when you go through it. So you want to extend upwards, put your tip up, and push everything down. And you march forward, and automatically you make it to the front of the face just like that. So we've released everything over the zygomatic complex. That's the inferior zygomatic line, and that's where we're locked. So the zygomatico-cutaneous is right under us. Now we're going to come upwards, and you can see the zygomatico-cutaneous ligaments are right there. You have your subplatysmal plane over the masseter, parotid gland right over here, zygomaticus complex right there, and your zygomatico-cutaneous ligaments. If you release the zygomatico-cutaneous ligaments up high, you will not mobilize anything distal to it. If you go too low, you will not mobilize anything. You have to go right in the middle here, and you cut it, and that's it. And now you can mobilize everything distal to it as you dissect in a superior-medial direction like this, which you're trying to mobilize the SMAS layer that in front of you will contain the superficial malar fat pads. Now you can see here we've released everything over the zygomatico-cutaneous ligaments all the way to the front of the face. And over here we have released the platysma over the masseter. Now you have this remaining. What these are the buccal decusating fibers, which is over the line of the parotid duct. You have these fibers that decusate the platysma going in from where the SMAS connects, just like the conjoint tendon. Same exact thing. What you want to do is pull forward and push down perpendicular to it. Pull forward and push down, small movements, pull forward, push down, just like that. Pull forward, push down, just like that. And that's that. So now we've released the entire deep plane over here. And what I want to show you is the anatomy now. Here you can see this bulge over here. This is your zygomaticus complex, which is your zygomaticus minor and major. If you pull up forward, you can see this gap under here. You see that hole? Anytime you see that, that's deep to the deep plane. That means you're under zygomaticus. So if you're ever dissecting here, you have to go above it and push that down. That's deep plane dissection. Here you can see it goes up in a loop. If you ever continue your deep plane dissection, you have to come up here and pull that down. But there's a vessel there. Here you can see the anatomy of the masseter. Masseter comes deep. Right over here, it goes into that buccal space. As you see here, the platysma overlaps the masseter up until that exact point. And you can see the platysma here becomes SMAS. If you see platysma, the color of it, and then it becomes yellow right here, that's the SMAS fat. So that's the junction point, which sits right on the insertion of the masseter. And if you look from outside, it is exactly along that line that we drew over here where you see the bulge. And if you push on it, that's where the teeth are. So that's the anatomy over here. Now we're going to go down and release what's remaining here, which is the cervical retaining ligaments. Now we're going to come back down here. We've released the facial platysma. Now we're coming to the cervical platysma. If you pull up on it here, you can see this is the lateral border of the cervical platysma. At the lateral border of the cervical platysma, you will have the EJ, which is right down over here, and you're going to have the great auricular nerve. So you do have to be cautious as you're making this incision over here. And our goal is to release the tethered portion of this lateral platysma, which is over the parotid gland. It is not over the sternocleidomastoid. Your sternocleidomastoid, you can see, is back here, starts up here and goes down that way. This portion, which is cervical retaining ligament, is on top of the parotid tail. And what we're doing is releasing off of the parotid tail and also taking advantage of the fact that the parotid tail has a parotid capsule on it, which gives this part of the platysma some strength. That's what adheres it down, but it's also what gives us strength for our lifting. So this is a very important move to make to give your flap some strength to pull on, but also to release so you can mobilize the remainder of the platysma, which is in a glide plane over the underlying sternocleidomastoid musculature. So the part that's adherent is not over the SCM, it's the part that is over the parotid tail. Now we want to go in and release bluntly, and again, this is another decussation zone like we saw with the conjoint tendon. And what you want to do is come down, lift up, put your tips down, and push down. So you come down, go up, tips down, push down. The reason you put your tips down is because you want to avoid tearing the platysma here. And you will come across some cervical branches here. People go over them all the time like they're nothing. There are cervical branches here. This is your parotid tail that we're pushing away. Tips are down. Tips are down. You want to make sure you're not hitting any cervical branches here. Tips are down. And you can fly through this, but since we're doing a video, I'll show you everything slowly. Slow movements here. Now, as you get towards the medial portion here, you stop. The submandibular gland is going to be right over there. You can see the tail of parotid goes forward and attaches right towards the submandibular gland. Embryologically, they are connected. Over here, we're just going to release a tiny, tiny bit more. And now we're released. So we have our entire platysma. Give me a long forcep. You can see the platysma here is released. It's no longer attached to the parotid. And we can manipulate it now and move it up with this entire platysmal SMAS flap. So you can see the platysma goes down this direction, as I said, follows that line. So the platysma, as I said, ends over here. If you look from externally, it follows that line down into the neck, around the EJ, and goes that way. There is no expanse over here like every textbook shows. It is right here, and it goes medial, just like that. So this is your platysma coming up, terminates on the face right over here, becomes SMAS, that is composite with the skin. The SMAS and the skin need to be connected. Inferiorly, if you go over here, you'll find the external jugular vein and the great auricular nerve, which on her are right here. That's your EJ. And then your great auricular nerve is just in this fascia lateral to it. It's usually lateral. Sometimes it overlaps it. And sometimes there's more than one branch. But you can see here, that's your external jugular vein. Your EJ, your great auricular is right here. What if you make this bleed? Not a big deal. You stop it by going like this. It stops immediately, and then you can just bipolar cauterize it in most cases. Here we just take a look at the flap or the shelf, or in Spanish, the pestaña, and we want to go and just have something nice to suture to. That's all you need. You can put your hand on the backside and dissect it just like this. Tips up. Don't cut into the SMAS and shred it, and that's it. So this is your entire dissection. Now we're going to irrigate and wash out the face. All right. Now we're going to do the suspension. The key to suspension is release. Key to not getting a pixie ear deformity is the entire surgery. Key to not getting scarring is the entire surgery. So all that release is what's most important. And we don't choose the vector. What we do is we start here. You can see the platysma. I'm going to throw 2 stitches through that part of the platysma. One is on the lower border right over here. One's going to be on the upper border. Throw it about 1 centimeter apart all the way at the edge of the incision. And the key here is don't pull tight. You want to find the right vector, just like the brow lift. If you pull here, there's pleating. If you pull here, there's pleating. If you pull here, that's where it wants to go. There's no pleating. Now, hers overlaps her entire ear, which means that's a massive lift. She wants to go about this direction. I pull 190, 145, you can see where it goes. The mistake people make is they pull and they look for the effect. The effect is a consequence. It will go to the best effect if you find the best vector. So this is bad vector. That is bad vector. You see? bad vector, great vector, gets everything. And you don't get any pleating on either side. So without looking at that, you can look at this. Pleating, stiffness, more compliant, more movement, no pleating. That's where you go. And then if coincidentally you look down, you'll see the result is the best all the way around on every part. However, this is overlapping the ear. We're going to reduce it. So here we're going to reduce the SMAS, lateral smastectomy. You want to do really as little as possible. It's always less than what you think. That's the thing and the key with the entire platysma. All of the SMAS, always remove less than what you think. There we go. That's perfect. See, I barely trimmed anything and all of a sudden it just goes where it wants to go. When she breathes in, it relaxes. You want to grab here to what we call Lore's fascia, or the paroticotympanic fascia. And you can see it is quite a vertical move on her, as we expected from her pre-op. When we were playing with her face, it looked like it was going about almost 80 degrees vertical. So what people show you with their face is what you should be doing pretty much in surgery, unless they're totally wrong. Again, you pull up and you see pleating, resistance, no pleating, no resistance, or less. Boom, that's where it wants to go. More lateral you go for your adherence point, the better off you are, because you get into what we call Lore's fascia. Now we're going to skip the middle area over here and go up to the upper midface, right there. I'm going to put my retractor here, flip it around, and here you have your midface SMAS. I'm using 5/0 nylons because you can use 5/0 nylons to lift the entire midface, which goes and shows you that you do not need massive anchoring, you don't need massive anything. All you need is good release, and it's going to go anyways. You can suture it with dental floss. You can suture it with anything, and it will go. You see how much it moves, and I'm barely touching it. Now it's moving so much, actually, that I need to extend her incision. Here we are with a 5/0 nylon. You can see where it wants to go, right over there. And you want to go grab that deep fascia, turn around so it doesn't pull down, it only goes up. Now we're going to flip around the next part, and you can see here the fascia. So you have to deliver it to yourself because it's a little bit buried inside. And again, I'm using a 5/0 nylon, and that will lift up the entire midface. Little tiny baby 5/0 nylon is going to lift up the entire midface. And you can see it just wants to go right over there. I'm just playing with it. Here, resistance, there, resistance, here, ooh, no resistance. That's where it wants to go. No pleating, no bunching, no resistance. Get rid of all redundancy. Give me a 4/0 and then a 5/0. Here we are on that corner of the sailboat. And you can see how it's kind of coming up towards the incision that we marked. There we go. That's a 4/0 nylon, and the last one, another 5/0 nylon right over here. And this just helps evenly distribute everything, and you never really have to tie any of these tight. Now these sutures, doesn't matter what you use. You can use almost any suture. I just recommend against Merceline in the face. I use it in the neck as a necessity sometimes, but you don't want to use it in the face. It's extremely inflammatory. You can use anything else. A monochrome suture is fine. Now you can see the angle of lift. And if you look at it relative to the Frankfurt horizontal plane, which is from here to here, you're about above 70 degrees on this lady. That's the Frankfurt horizontal plane. So that's the angle of SMAS elevation on this patient. Another patient might be less, might be more. Here you can see we're just going to tie it down flat, horizontal mattress. You want to take a look, no tension. Put it back. I hold it towards myself, just like that. Make sure it doesn't tie any tighter than where I left it. Just like that. Again, no tension. If you have any tension on this flap, it will cause ischemia distal to it. In addition to the ischemia, it will have given you or provided zero benefit. So you pull towards yourself, tie it right there. That way it never goes past the knot. It just stays right there. And you can just tuck in the stitch underneath. And these stitches don't cause any issue. I've used them for a long time. Otherwise, it doesn't matter what you use here. You could use a PDS, you can use Vicryl, monocryl, and it all works. Now on these I don't really need to check because I'm going by palpation. I can tell it's not going anywhere, it's not tightening it, it's fine. Now, those lift to where they want to go. The two superior stitches can overlift because the midface is nicely released. So it can actually go too far on some patients, meaning past the plane of the zygomatic arch, which you don't want it to do. This upper limb of the sailboat starts diagonal and it starts to become horizontal. You don't want it to go above the horizontal. Pinch up. So you want to just see where it sits, take a look, and that's actually pretty good. Release it a little bit. Great. Pinch over here. And you want to leave that knot right where you tightened it to, not to have any tension. It is a fallacy to believe that you can redistribute tension. Deep to superficial, tension is tension. It's a fallacy to believe that a little tension gives you a little bit bigger improvement. That is not real. It is not true. Hold that there. It's imaginative. I know because I've tried, and it does not give you more of an improvement, just more negative effects. There we go. Release it a little bit. Pinch it up this way. Don't move. We're going to keep that knot exactly where I left it, right there. I could go more, but it's going to lift past the horizontal plane of the zygomaticus, and I don't want that because then you get indentations and irregularities just from that. Now we're going to go into the neck. You can see everything sitting nice and comfortably over here. No tension, it's loose. Now we're looking at the lateral platysma to try to suspend it. When you pull it upwards, you'll see that it tethers around the gonial angle. What you want to do is recreate the gonial angle by drawing it. It's right there in a little L shape, just like that. And you can create a partial myotomy to allow this part of the platysma to inset, just like this, in the shape of the gonial angle. The thing to watch out for here is not losing too much integrity. If you see here, as I pull, I'm getting movement on the infragonial or inframandibular platysma, which pulls directly against the submentum. If I do any more myotomy, I lose the strength of the inframandibular platysma, which is the 2 centimeters inferior to the mandible. On a tall ramus, you lose that very quickly, so you have to really limit the amount of myotomy that you do there. The reason for the myotomy is to allow this platysma to inset behind and allow that platysma to stay high. So here you see we're going to grab this lateral platysma, the cervical retaining ligaments. I'm using a 2-0 Merceline suture. And you have to really get a feel for the needle going through to make sure it's nice and strong. If it's not strong, it'll tear through. So you have to do what we call a whip stitch instead of this horizontal mattress suture. Now the movement we're going to make here is not pulling it as far back as humanly possible. That's a mistake. It's about recreating the 3-dimensional contour by going back a little, up a little, and then deep a little. And that's going to give us restoration of contour and restoration of all that submental architecture and position of the hyoid. Most people pull here as hard as they can, and they feel like it moves more, but they don't see that they're not getting reset of the entire submandibular triangle. You have to come under to do this, and the key is you're looking externally at the mandible at the angle as your fulcrum. So what you want to do is entrap the platysma deep to this angle and pull it up underneath so you get a sling right around the angle of the mandible, and that's what we're doing with the mastoid crevasse, and that's going to give you all the improvements all around there. Now down over here, give me a bovie. Now we're going to create some depth. If you were to just tie it back to the mastoid, you're very dependent on the height of the mastoid. Is it broad? Is it narrow? Is it shallow? What I do is I bypass that by doing something called the mastoid crevasse. And that is where we come along the anterior mastoid line. You can feel the anterior mastoid line right there. And you just make a vertical incision all along that anterior mastoid line, just like that. So here you have your anterior mastoid line, and you want to create a vertical cut all the way the anterior mastoid line. The 3 components on the anterior mastoid, as you can see, are inferiorly the sternocleidomastoid, right over there. That's the sternocleidomastoid. Here you have the parotid tail. You want to always feel the anterior mastoid, and then superiorly, you can see you're under the ear canal. So the ear canal sits on it too, the contral bowl. So what we're doing is releasing the parotid off of the anterior mastoid, releasing the fascia there, allowing the parotid to inset. If you want it to inset more, you just release the fascia a little bit. Never cut away the fascia. But you can go under the nerve and you can release this fascia a little bit, and it makes this more compressible. That's a little lymph node over there. So now it's a little more compressible. You can always trim any excess just right here. Not of fascia. You'll get a cyaloma if you do that. So here you see it's a little more compressible. That's all you need to do. I recommend most people do not remove gland from there if you don't have a good grasp on this stuff. So don't remove gland. You're just going to cause a cyaloma on your first case. Don't do that. But releasing it, totally fine. Keep it encapsulated. Want to bend our needle, and I want to look over here and take it as vertical as possible. So the reason it goes as vertically as possible is because, again, we've slung it around the gonial angle. So you just want to go as vertical as possible. Your fulcrum laterally is your gonial angle. We're grabbing the anterior mastoid, entering and exiting as high up as possible in the anterior mastoid. That's why it's important to get as vertical, and you can't get this vertical without doing this technique. Or deep. That's what the big difference is that depth allows you to go deep to the gonial angle and sling the platysma around it. Huge difference. Now, some patients luckily have that architecture and it doesn't really matter. Most patients do not, and this allows you to bypass the patient's own architecture. So here we have our two omersalines. They can cause problems. However, if you just throw two knots and you're kind of deep in this hole, unlikely to. But always remember that you place them there in case you ever develop something weird in the future. We throw a surgeon's knot. Now, we're not going as far back as possible. We're going vertical, about 1 centimeter, back 1 centimeter, and deep 1 centimeter. So you see it's the X, Y, and the Z. So you're going 1 centimeter back, 1 centimeter up, 1 centimeter deep, rather than trying to pull it 2.5, 3 centimeters back. This gives you a better improvement and is more anatomically correct because it pushes the parotid tail back into the deep pharyngeal space and does not overlap platysma onto mastoid where it does not belong. That's why people get blunting. They're overlapping things. You shall not overlap these things. It's like the 11th commandment. All right, there you can see it just goes deep and it sits. And most people struggle with that because, again, they're trying to pull as far back as they can. They think that's what gives you the lift. It is not how far back you pull. It is about going in the proper vectors. Now here you can see we've created some depth and proper position, but she's tethered. So I have to release a little bit, long forcep, and you can do that with a little fasciotomy or a release, or you can slim around the infragonial fat, and if you slim around the infragonial fat, you can see you're automatically performing fasciotomies. So you don't want to do too much, just enough that it allows it to release a little tiny bit. And then from here, you can do these partial baby fasciotomies and myotomies to allow it to spread around the gonial angle. And you can see how this distance is getting taller and taller. So this is now our gonial angle depth. And if you look from outside, three-dimensionally, you can see how this was all recreated now, this line. So we slung it deep to the gonial angle and up over here, and it's pulling against the entire submentum. When we pull against the other side, now we've really raised the hyoid position. A few things to note here. You can see that the mandibular ligament region, which we marked underneath the chin, rotated upwards. No release was done, yet there's no indentation there. That's because the fat graft corrected it more properly. The hyoid position is already higher, partially because I reduced the digastric angle, and then we put the platysma in front of it, and now lifted the platysma up and over this way. The larynx came back a little bit with it as well. Now we're going to excess trim removal over here. You can see anytime you elevate skin off the SMAS, what happens to it? It starts to retract. You lost its support structure. That's why we don't want to elevate skin off SMAS. This is getting rid of the redundancy with the lack of support. This is pulling it way too tight. So you want to do is just get rid of the redundancy right there. No tension. Find your little mark. Tacking sutures do not do anything positive. So you don't need tacking sutures with a lot of tension on them or anything like that. It doesn't do anything beneficial. You cannot redistribute it. You want something like this that just closes with no tension. You got rid of the redundancy. Fantastic. If anybody's ever helping you hold this up, you're going to cause scarring and failure. Now we're going to come against the skin over here. Never pull tight this way. Nobody ever ages in that direction. It's not a correct vector to pull in. So you just want to see where the excess is and get rid of the excess. Just like that. So here you want to make sure that this lateral horizontal line that comes across the canthal line stays lateral. You never want to sweep it upwards or anything like that. So you want to keep that lateral. You want to throw small bites over here and try to avoid getting the hair follicles. If you get the hair follicles, you're going to cause hair loss. I don't throw dermal sutures because they're not necessary, and again because they cause hair loss. Hair loss is the only thing that would scar here. Otherwise, this area heals immaculately and quickly and faster than the other areas on the face. So you throw a couple sutures. You don't need any vertical mattress. All you need to do is put it back together with as little trauma as possible without hitting any hair follicles, and that's it. Over here, if you're ever getting any bunching or fluid collection in the temporal region, you can throw tacking sutures. If you do so, you have to do so vertically. Do not do them horizontally. Let me get another 5-0. Do not do them horizontally, or they're going to cause worsening of the pleating or bunching that you get. Transcutaneous sutures or percutaneous sutures do not cause ischemia unless you over tighten them. Dermal sutures cause ischemia. And you can throw 3 of these, 4 of these, really whatever you want. And you just take them off in about 3 days. And they do help this area heal a little bit better, because sometimes if you have a head wrap on, the skin bunches onto itself at touch. So this is a nice, easy thing to do. Now we're going to put in a drain. I put a 10 French round drain with a trocar. The reason I do this is to form a little suction here so the skin adheres down to where I want it to be. It helps redrape it. That's the main reason for the suction. Otherwise, it comes out the next day. It is not a suction that we really care about for hematoma or anything like that, but it does help with minor amounts of fluid collection. And the less fluid collection you have in the first couple of days, or even the first night, the less chance of seroma and things like that over time. So you just leave this loose. You can take it out the next morning. Double prong brown 1540.
So I want to demonstrate something here about skin dissection and skin laxity. If you look over here, you can see that the skin looks super, super tight, looks very healthy, it's bright, and you can bounce a quarter off of it. Okay, this is after I did my facelift and muscle suspension. Now, if you come here, you'll see where I dissected skin to. I dissected skin in my facelift only from here to here and only here. So that's the skin elevation on the entire facelift, is that. If you look at the skin quality here, it looks amazing and it's tight. If you look over here, even if you pull on it, the skin looks more crepey because you released it from its support system underneath, and it has a tendency to bunch or retract, and you have to re-stretch it just to make it look okay. So this skin, which is not dissected, is tighter and healthier than this one over here. Just a concept.
As you come over here, you'll see that we want to get the ear out of the way without pulling the ear into the flap. Now, most people, the mistake they make is they try to pull the skin that way. However, the rest of the lift was this way. So if you go this way, you see there's pleating. If you go this way, you see there's pleating. If you go this way, you'll see there's no pleating. That's where it wants to go. And again, we elevated skin and delaminated, which means it starts to retract automatically. We have to get rid of the retraction, but don't put it on tension. So we're in this middle area right there. You want to tack it down just to this area with no tension. So you see I just cut it to where there's going to be no tension. And we just get rid of the redundancy. So it's the balance between no redundancy and what would be considered tension. So here you can see we close it with no tension. Just like that, goes no problem. So now you see here, most people, again, with no tension, they would just come this way, not realizing that there's bunching over there and a dog ear. It has to go this way. So this is where you want to go. Now you could just cut it across, or for sake of demonstration, you can throw in a little tailor needle over here, and you can leave it there. Now if you see that's where it wants to be, you're going to come right across over here, and you're going to follow right down over here, just like that, and we get rid of our excess in that direction with no dog ear ultimately on the end over there. And that is the appropriate place to be. Everything again gets pulled up vertically just like this, and you want to tack to that vertical point. No dermal sutures are necessary. And these are 4/0 nylon sutures that come out at 1 week. Putting tension back here is not going to give you a better result. In fact, it will do the opposite and create hypertrophy. And you can see that you don't need to extend the incision much, not even in massive necks. I've done this in huge necks, and the incision maximum goes 1 centimeter more than that in the biggest neck I've ever done, and I've done very big necks. Most people extend it because they lack the understanding of the proper vector you need to lift in. And that causes them to think that there's all that excess skin because they form a dog ear, because they went in the wrong direction. So same story as the rest of the face. It's really about understanding the vectors of aging, the vectors of lifting, and the fulcrum against which you're lifting, because that will determine also the direction that you need to lift in. The fulcrum back here is right back there. Okay. Interesting thing to note here is I threw my 4/0 nylons now, and put a 5/0 vicryl through the skin. No dermal sutures. These are interrupted sutures with a 5/0 vicryl. The reason I do this is I have a lot of patients from out of town, and they leave and we don't know what they do. So I like to place a couple of these sutures that they never even notice. They come out in a couple weeks because they're tiny, and we cut them right on the knot, so they don't really notice them. And I put them here at the base of the earlobe. It's prevented a lot of issues. So the number one patient favorite thing to do after surgery is to yank on their ears. The number two favorite thing for a patient to do after surgery is to take photos of them yanking on their ears and send it to me. The number three favorite thing to do is a patient asks you something and you say the answer and they ask you, are you sure? So those are the 3 favorite things for a patient to do after surgery. But I can prevent the first 2 with just doing a couple of these little vicryl sutures. Now we're going to finish by trimming this skin around the ear. You have to realize that you want this to tuck behind the ear, so you really want the level to be at the base of the conchal bowl, which is right here. So you determine it relative to the base of the conchal bowl, right over there. And before you get to the end, always pull the ear out, push it down, see where you are. And just keep doing that until, boom, you're in the front of it. So you don't want to ever cut too much. Back over here, you'll see you want to leave the skin excessive enough to roll over the back side of the ear, to wrap around the back side of that sulcus. And then we're going to go down and trim just to the point where it's touching, just like that. You really want it tucked in over there. Okay, fantastic. Up in the front over here, you want to look at the apex of the ear, which is right there. So you can pull up that way, cut upwards. And now we're going to cut back to that apex again, just like that. And you want to let that fall in. Just like that. And always cut less than what you think. That's the lesson of trimming. Is the price is right. Always cut less than what you think. bid under, not over. There you go. That falls right in there. Back is great. Let's get 5/0 nylon sutures. Up here you want to throw your peak down into the trough right over there. And then you can run the remaining of the pre-helical crease. If you kept good volume, you don't have to worry about dermal sutures here. Dermal sutures anywhere on these facelift flaps can cause ischemia, and you have ischemia already on every facelift that you do. It's always there because you've elevated a tremendous amount of skin. So you always have ischemia. The thing is, you just never want to see it bad. Over here, you want to do vertical mattress sutures, and the way you do that is approximate the two medial sutures, grab the stitch, flip it in your hand, reverse it, don't let go of the tail until you've pulled all the way through, and that way you don't ever catch it by accident. So vertical mattress sutures will help you here because there is a tendency to have inversion in these pre-helical or pre-tragal incisions. So just like that, you flip it around and reverse it. You see on this part, we're going to throw 5/0 vicryls, again, because patients love to pull on their ears. Okay, let's get a 5/0 plane. Okay, now we're going to close the post-auricular sulcus. And you can see what we do is just use a 5/0 plane gut. Close it in a running locking fashion. And the key here is to take small bites and always pull the ear side out as you're stitching, because it has a tendency to cause sinuses or pits as it heals. So you always want to grab the ear part and pull it out towards you. So here you can see we're just using a 5/0 running locking suture and taking small bites so you don't cause hypertrophy of the area, and also pulling up on this ear side of the flap so it doesn't cause any kind of sinus or pit after closure, which is pretty common. It seems like an inconsequential closure. However, patients do place their fingers behind their ear in the healing, and they love to feel it. So it does help you to do a nice closure back here. Okay, this will come out. The last part we're going to do here is called a sulcus forming stitch. The sulcus tends to blunt a little bit, as you see. It's no longer adherent in there. So we do a sulcus forming stitch where I use this suction to help me out. I push everything in, and then I'm going to grab my 5/0 plane gut and push the sulcus back into the deep fascia right on the outside of that stitch line, and tie these down over here, which is going to push the sulcus skin back in deep where it belongs and gives you that three-dimensional contouring again. The benefit of this is that the skin, first of all, stays where you want it to. The other benefit of this is that you end up getting less hypertrophy or thickening behind the incision because there's no dead space to form any kind of fibrotic scar tissue. It does not prevent pixie ears. The only thing that prevents a pixie ear is the entire surgery. Now we finished this side. You can see where that sailboat ended up. So this is that sailboat modification. This is your original Petengues line, which went from here to here. This is your sailboat modification, your deep plane entry point, which originally was here. It has shifted upwards and come up here, and you can see that gonial angle has shifted from down here up back onto the face. And the platysma, which we had drawn over there, came upwards and inwards, didn't come that far back. So you see the proper movements that you make when you do a facelift and how much it moves, as well as the rotation of this mandibular ligament region, which was actually underneath her chin beforehand. Here we're starting the second side. You can see the sailboat modification of the deep plane entry point, which means our skin excision or skin elevation is going to extend in this region down there, very small amount. And then down into the neck, we're going to do some skin elevation right around there. We start with making our incision here in this patient in the pretragal crease, which we marked preoperatively. Again, it does not matter if one side is pretragal, the other side can be retro and vice versa, or both the same. You really do whatever matches that individual side of that individual patient, wherever it hides better. Here we determine preoperatively how high to go on the temporal tuft incision. Does not matter if you bevel it or go perpendicular, there's benefits to both of those. Posteriorly, you come in this postauricular sulcus, very gently across, and then follow this hairline down. Again, very gently attaching behind the earlobe. Again, if you have to do any kind of anterior-posterior reduction of the earlobe, you can do that at the same time. Or you can do it at the end of the case. I do not like doing wedge resections on the ear. I think it heals a little strange. Okay, Brown. Here you start pulling out at the apex, and as soon as you release a little bit, you can usually start to peel it away from these superficial temporal vessels. Hold on, this patient, it's adherent. And you want to just come into this layer of hypodermal fat. So you don't damage the dermal plexus. Here you elevate just under those hair follicles, leave a nice thick flap there. And now we're going to switch over to our bear claw. It's an Anderson bear claw retractor. We're going to do some skin elevation now. So for the skin elevation, you can see we just pull towards ourselves while the person helping you pulls away, and you can dissect nicely into the proper plane. Let go for a sec. Again, pull. So we come here into the hypodermal plane, and you release out right over there. Now we're going to go into the face in this direction. Pull downwards here. You can see we're going to now release again in the hypodermal plane. Coming around the gonial angle into the neck. Let go. And now we come across the level of the mandible all the way into the neck. Now we continue with our post-auricular dissection. I'll pull up the ear. And now we want to just lift up the skin again in a directly hypodermal plane. When you pull up on this, you got to make sure you're following the arc of your elevation. Stay in the direct hypodermal plane, and the goal here is to not go too deep, where you're going to damage any auricular branches, and not go too superficial, where you damage the blood supply. So we're going to continue with retraction against me, going down into this hypodermal plane. And the tension, counter tension, allows you to go properly without any kind of buttonholing or changing of your plane inadvertently. Now we've opened up to the preplatysmal plane. So now we're going to do the skin elevation into the neck up to that level of the thyroid cartilage or the superior portion of it. So a few centimeters over there. Coming underneath, we're going to do blunt dissection by retracting up and then pushing down with our Stevens K scissor, just like that until we meet in the midline, and then making sure we've released along the border of the mandible. No need to go above, just like that. All released. Now we're going to go and start our deep plane dissection. Right now we're going to start the deep plane entry point. We start here at the lower part of our sailboat. We rotate over, and when you do this, you can see again the entire line of the lateral border of the platysma, which is right over here. You can see me moving it. This is the lateral border of the platysma, and you can see that line right there that folds onto itself. That is the lateral border of the platysma. Then you go up here, it turns into SMAS, and then we're going to continue up here again as SMAS. So that's going to be our deep plane entry point. 10 blade, please. So here we put some back pressure, and you can see again where it folds. This is your deep plane entry point, and you want to come extend by putting some back pressure. Here you can see we've opened up the deep plane entry point, going under the SMAS over here, under the platysma or through the platysma, and there's your parotid. Now we're going to move up to the deep plane entry point over here, and you can see that I'm going to bevel my knife to come over zygomaticus over here. It allows you to keep a nice thick flap without damaging the muscle. Now, if you ever do damage the zygomaticus muscle here, you should just reanastomose it and put it back together so you don't get smile block. Now we're coming and releasing over the parotid gland, pushing away from the platysma in what we call the deep plane. And this is the lateral portion of the deep plane that is fixed to the platysma, which we call the fixed SMAS. As you go anterior, you're now over the masseter muscle, and you're into what we call the mobile SMAS. And you can see how this just opens up with no resistance. Up to the facial artery is where we go. Now we're going down into the neck, and you can see the talar parotid is here linked up against the lateral platysma. You want to get in there and start pushing the talar parotid away, and then get deeper and deeper into the neck with your tips pointing downwards. So you go deep into the neck without cutting the platysma. And that's all you need to do to release that. Now we're coming up to the midface, and you can see the zygomaticus muscle over there. It's a little tethered. We're going to come right over it, and then we can start going bluntly. I'm going to have someone hold the retinacular suspension that we did over there. And as we get over the zygomaticus here, you see we just bluntly spread inferomedially as we march forward, and you will come across some lymphatics here in the midface. Here we've marched along zygomaticus all the way to the front of the face, just with doing scissor blunt dissection. If you look from the outside here, this is where we're going to be locked into the zygomatico-cutaneous ligaments. So we elevate up again. You can see the zygomatico-cutaneous ligaments right there. And what we're going to do is just come cut right across them, just like that. And that's going to allow us to start splaying and going over the rest of the zygomatic complex inferomedially down into the face. Now here you may see a transverse facial artery perforator. You can preserve that if possible or cauterize it. I'll go around it for now. And you can see the dissection just continues anteriorly there with no problem. The remaining section here is the buccal decussating fibers, which we saw on the other side. And to get those, you just pull up against this joint, push them down in a perpendicular fashion, using your left hand to really pull. Now there was a perforator of the transverse facial artery, which we're going to grab and cauterize both sides of it. Now we're going to continue releasing the buccal decussation line by just marching forward and pushing down. The key here is to really grab your retractor up and forward, and then you can push everything down once you go up and forward. So now we've released everything in the midface, as you can see, and now we're going to go release the remainder of the neck. Now we're going to release the lateral border of the platysma. You can see it as it comes up over here. Going to make a gentle incision to avoid damaging any of the auricular branches in case they're there. And then we're going to follow along by elevating slowly off of the parotid capsule and what we call the cervical retaining ligaments, making broad strokes, narrow strokes to make sure we don't come across the external jugular or the nerve like we are looking at right over here. Here we're going to release a little bit more of that fascia. Just like that, keep releasing as you go forward over the parotid capsule on the underside of the platysma. And then once you're through enough, you can go bluntly and now release everything just like this by pulling forward, pushing down, pulling forward and inferiorly pushing down. And you may encounter some cervical branches here. If you do, realize that they are cervical branches and not just some random fibers. You want to keep those intact. So here we do blunt spreads until we can release off of the attachments, just anterior, going up to the facial artery. And here she's got a bunch of connections which we will leave just intact. Here now you can see we've released off the platysma from the parotid capsule, which this is the parotid capsule. This is what you call the cervical retaining ligaments. It's what has the most strength, and that's what we can use to really pull against and mobilize the platysma. Up over here, right over here, the platysma transitions to SMAS, and that's as the masseter goes deep, and you can see that externally as this line that we drew right over here. Now we want to check if we have an adequate shelf to the SMAS and platysma, so we just use our hand pulling forward, a little bit of back pressure over here, and create this shelf of SMAS to stitch to all the way up to the top of our sailboat right over there. And fantastic. Here, just like the other side, she's overlapping a little bit on the platysma, so I'm going to trim a little bit of that SMAS platysma complex right here in front of the ear. Now we're going to irrigate her out and then suspend. Here is something that is often overlooked, but as I was elevating over the zygomaticus here either distorted or tore a little bit. If you leave that alone, it's probably not a big deal, but let's say you had done this more proximally over the mid portion of the zygomaticus, you get something called smile block. Smile block is a disjunction or a muscular retardation that occurs in the middle of the zygomaticus where both sides will flex against each other and form an indentation. What you should do if you see this is reanastomose. So you take it back to where it was and you just reanastomose it. It's a super easy thing to do. It is not a big deal, and it's something that inadvertently happens and people don't notice it. And even happens to me, I guess. But it is something I warn people about all the time. Not a big deal if you identify it. If you identify it, you put it back together, nothing ever happened. Not a big deal. If you don't identify it, then yes, you can get smile block and it's difficult to treat. And you typically have to either reanastomose it later or you put volumetric support under it, and it helps. So this is just a 5-vicryl, and the zygomaticus fascia, where the muscle turns into fascia laterally, is completely back together. And to be super safe, I'm throwing a couple extra sutures just next to it. And that's it. Now we're going to do the suspension. The first 2 stitches of our suspension go down here at the gonial angle into the facial platysma. And this is a 3/0 nylon, but again, you can use any kind of suture you so desire. It does not matter what kind, as long as it's not Mercilene in the face. You want to pull up here to see where it wants to go. Naturally, it wants to go there. Again, I'm not looking for the ultimate effect down there. I'm looking to see where it wants to go. Here it pleats, and it gets stiff. Here it goes with no resistance. And it goes maximally. That's where we're going. Tacking into Lore's fascia, also described by Labbe. And we're just grabbing the lateral edge over here of the platysma, and then ultimately the SMAS. Give me a scissor, it's overlapping a little bit. Thank you. Just like that, little tiny movement declares to you where it wants to go. Over here, we're going to get up to the top of the facial SMAS, flip it around so you can find it right over here. And grab the little ledge that we have using a 5/0 nylon suture. And you want to see where it wants to go, right over there. 5/0. Fantastic. So here you can see that's where the most movement is. If we go this way, it gets stuck. That way, it gets stuck. Here's really where it just wants to go. And ultimately, if you look down to see the greatest effect on all areas, this is going to provide it. But that's not what I'm looking at. You know what? Okay. Now again, you can see all the vectors are about the same between the sutures. They don't taper off as they go higher because we performed a proper sailboat entry point. Now we're going to tie them down one by one with no tension. Do not want any tension on this closure. It will not help you. It will only hurt you. And it hurts you in so many ways. Try hands with the tips up. Okay, here's where we have to watch out to make sure we don't overlift. It goes so easily. Nope, not overlifted. Pinch it up. Grab it. Bye, Paul. Let me get a 15. To go. Thank you. Make sure not to tear any of the stitches. Okay, good. Don't crush the facial nerve, make sure. Okay, I'm gonna get a long forcep. So here we're just gonna allow this to splay by spreading it across the gonial angle, just like that, and there's our little transition point over there without losing any of that strength. Round 15 for So you see this skin movement is more horizontal than the other side. So if you look at the nasolabial fold for this patient, most likely is broader on this side and is more vertical on the other side. And it is, if you go look at it. So this came more this way. I need a 15 blade. So again, you don't choose the vector. You feel the vector and it tells you where to go. That's a very important part about this surgery. 5/0 nylon. So here, horizontal line stays horizontal. So here I'm just trying to tuck this back underneath. Just like that, and then we'll go to vertical mattresses. So now here we're going to place the drain, trocar, 10 French round. All the way across to there. Perfect, double prong, brown 15 and 4/0. So here we're going to elevate to where it wants to go, where there is no redundancy on either side. When we elevate it here, it just gets to that point, so it doesn't need any skin excision. 4/0. And then I'll take a 15. Just right over there, fantastic. 15. Here you want to pull up exactly where it wants to go, which is vertical, which is a little bit more skin excess on this posterior part than on the other side. 15 blade, please. Scissor, Storis. Okay, 4/0. Okay. All right. In a minute, we'll take some 5/0 Vicros. I was trying to come up with a name and came up with 20 ideas of scientific names and acronyms and other types of names, and then I had a patient tell me it didn't even feel like she did a facelift, it didn't feel like she did a surgery, it feels like I just lifted her aura. And so that was one of my options as the names, because I like that. And then everybody in the office, they're all girls, so they voted for that.
I didn't vote for that.
Yeah, you weren't here. It was in the old office. It was in 2014, 15. Cupid, it's an acronym. It stands for the relaxed skin tension lines in the lips, CPIND. And that was by accident. I didn't plan that. I wrote the article and I had a sketch drawn and I looked at it and it said Cupid. And I'm like, what? Because I was trying to describe the relaxed skin tension lines with numbers and names. So I gave numbers to the lines and then I gave names to the relaxed skin tension lines. Well. Now we're finishing up by doing the submental closure. The incision always looks wider at the end than it did at the beginning because of the rotation onto the face. When you grab the lower flap to bring it upwards, you just have to make sure you don't take a big dermal bite or else you get indentation. So you just rotate it right around and you close it like that. This is the only place that we're placing any dermal sutures. If you wanted to do any other volume augmentation here, you could imbricate at the junction of the mentalis and the platysma, but I believe everything looks to be in order after the fat grafting and lifting, so I don't think she needs that for the witch's chin anymore. So we're just going to close it up with a few 5-0 vicryls deep. We have our alignment set in place. Sometimes it shifts over a tiny bit. You want to make sure there's no fat that ends up inside your incision. And if you wanted to externalize some of these vicryls, you could. Same as we did on the other part of the face. Let's get a 5-0 nylon. Here, even if we don't do any kind of netting, you could do a few tacking sutures to make sure the skin doesn't move during the first couple days of healing. You just leave these on about 3 days, and you can place one here, one there around the neck, and it'll prevent movement or migration of the skin relative to the underlying platysma. It just kind of tacks down into there. You just need a few on each side is usually adequate. If you feel as though you need more adherence to prevent bleeding or anything like that, then you can do running netting suture, which is very beneficial in those cases. And you just do a simple running using this 5-0 nylon on a PS2 needle, and you can take that out at 3 days. The thing to be aware of with these sutures is that anything north or away from the above the sutures relative to the suction is not going to have any suction overnight. So just be aware of that. So here I just like to throw a couple, tack it down into the platysma. I'm not too concerned with hematoma on her, but her skin isn't fully behaving in terms of just like sucking down onto the platysma. So I just throw a couple netting sutures or tacking sutures here, which are pretty safe, and they come out at 3 days. You see I'm going horizontally across the crease. Ooh, so close. That way you never drag across the crease inadvertently. It is a mistake to believe that these types of sutures enhance any kind of result. They do not, but they do prevent complications like seroma, hematoma, and skin migration or bunching during the first few days of healing. Although if you want true prevention, you should do an entire running netting suture. But this is great for her. That's all she needs. Now we finished the case. You can see we started with a lip lift, symmetric, good exposure of the corners. All the weight is off the side over there now. We went to do the brow lift over here through incisions back over in the hairline, curvilinear in fashion. There's a horn suture on each side, which is going to be removed at 3 days. And you can see the arc of her brows are more symmetric. They are a little bit straighter, and her brows have evened out a little bit. As far as upper bleph goes, we filled in this deflated infrabrow region. She has nice even height all the way across, as well as her tarsal platform. Inferiorly, we did a lower lid blepharoplasty, only with skin excision, which again is uncommon. I typically do lower lid transconjunctival fat repositioning with a little bit of fat grafting and a TCA chemical peel. And her, she just had a little bit of skin excess and not really a skin that I wanted to do a chemical peel on. So I removed a little bit, and to support it, I did retinacular suspension on both sides, which means I did not release the canthus, which is great because it lowers your risk. Face and neck lift, we went into the neck initially and contoured the deep submentum by reducing the insertion point of the digastric inferiorly a little bit, made her a little more acute rather than obtuse. Reduced the gland right here, which made her a little slimmer and narrower from the front view over there, so her larynx isn't so broad anymore, and that really allowed me to grab the hyoid and sling it up over here. So the hyoid is your anterior fulcrum, which you wrap around and you're pulling against, and then you sling it under the jaw and bring it up this way. So you have to be deep for this fulcral pull to work. So here all you have to do is pull vertically, and it pulls around this angle. So it's like a pulley effect. You're pulling around this, and this is where the pulley is. And that's what brings everything up, including all the way down to the chest across the clavicle. You can see here we made a pretragal incision on both sides. Sailboat ended up into the crease, and we have a couple tacking sutures here where the skin is a skin-only elevation. This is skin-only elevation. So I put a couple tackings where I did that. Everywhere where it's composite needs nothing. So you can see almost the entire facelift is composite, except for the temporal region and this area in the neck. We're going to put a little gentle head wrap on her tonight. No compression. It is a loose head wrap, and it's going to just keep things covered overnight. We take it off in the morning. Drains come out in the morning, and we do not do any compression after that. She's going to see decent results in about 3 weeks, where she looks decent, not great, and 3 months is when she is at the point where a twin sister can't tell. You can see already the witch's chin is gone, and that is a consequence of fat grafting into that area. When she smiles, it's not going to indent into that anymore. And it's a consequence of pulling the hyoid up to the level that's behind the chin. So now she goes straight this way, and it's not going to have a strain that indents into the submentum anymore. That is that. Right now we are 2.5 months out from surgery on this comprehensive facelift with our lovely patient over here. And if you refer to the video, you'll see that we did a lateral endoscopic style brow lift, upper blepharoplasty, lower blepharoplasty with just skin excision and retinacular suspension, which we'll go over. Lip lift, so cupid lift with this design of 6.5 millimeters centrally, 7 on that side, 7, 8, 9 on this side. 0 millimeter incisive display before, and the fat grafting that we did all around the face with the aura lift. And you can see the corner lifts and where we put all this. Now the interesting thing here was the witch's chin, which I marked preoperatively underneath to add fat in there to support out the transverse mentalis muscle and the connection of the platysma to the lower neck muscles and the facial muscles. And here you can see the improvement of the witch's chin and how the strain improved and how much that line improves coming down. We lengthened her, suspending the hyoid by releasing the digastric insertion on the lower part of the hyoid fascial sling, and then you can see how we lengthened it, because here the muscle is contracting really, really strong, so the position of the digastric had to be corrected and was taken up with the hyoid behind the mandible. So the hyoid, you can see here now, is at the level of the mandible, and that is what repositioned the digastric into a proper position instead of flexing over in this direction. You can see the witch's chin has improved because she has support under here, and the chin doesn't flex down as hard and the neck doesn't flex in as hard. So those two things are what improved it. Better hyoid position and support under the chin, and then the vertical lift. And these smile lines improve all the way onto the face. So we're going to skip here forward to the smile lines, and you can see on the face how strong these smile lines are that come circumferentially all the way around like a little horseshoe, and how the chin just dips and flexes so hard. Now the chin's unable to do that because it's supported, so it doesn't collapse. It's no longer ptotic. And you can see how much the smile lines have improved all the way around to the side of the face. So we're talking about here on the side of the face, and that's what follows into this witch's chin right there. If you follow it, you can't see it. You want to see it?
No, go ahead.
I'll show you. Okay, this is what I'm talking about. She hasn't seen the photos yet.
Yikes.
Yeah. So this is what you see. This is what I was talking about with the smile lines. Your smile line goes all the way here from the side of the face, and the smile line occurs from lack of support across the mandibular ligament or the prejowl sulcus, and then goes down into the witch's chin. So it's a contiguous line. Most people don't know that. Most people don't see that. I don't think it's been very well described. However, these smile lines, if you follow it, follows straight down from this lateral cheek, goes into the prejowl sulcus, which is in front of the jowl there, where the mandibular ligament is, and follows straight into the neck. So you actually, circumferentially in this area, get a little bit of fat loss, and you can get collapse, just like you're seeing there, and strain on the face. Now, as the strain in the chin decreases, the strain on the face relaxes. So then you don't see that depression as much anymore. That's anatomically how it's happening. Now let's look at everything else bit by bit. These are her incisions. We went pretragal on this side, and you don't really see the incision. This is no lasers, no nothing. Temporal tuft incision over here. Okay, so you can see the postauricular incisions are healing great. Now over here to the lip, if you can show the lip, put your chin up a little bit, you can see, you can't really see the incisions, nor the corner lift incisions, which everybody worries about. You do have to be prepared to treat them. And then now let's look at the mouth open. If you just drop your mouth open, now you have about 3 millimeters of incisive display. So if you look at the before and after photo, you'll see 0 incisive display beforehand, 3 millimeters afterwards. And when she closes her mouth, it's nice and relaxed in a relaxed closure, which means we did a proper type of lift. If you want to see over on this side, I'll show the incisions over here, how they're healing. Again, this is without any laser, with nothing. This is just standard follow-up. And then you can see the incisions, how they heal on the temporal tuft with no dermal suturing or anything. I do have them use minoxidil here to increase speed of incisional healing. And then back here you can see how everything is and how nice it was that we tuck that sulcus back in there so you don't get any kind of hypertrophy back here. You can see how soft it is even if you pull on it hard. Sorry about that, but pulling on it hard, you usually would see hypertrophic change coming across. You don't see that over there. All right, so I'll just review again the before and afters here. You can see why we used a pretragal incision. She's got a tall incisura, it's well defined, and she's got these wrinkles in front of it that you want to get rid of. You can see the deflation changes in the ear, how much healthier the earlobe looks now, and how well it supports an earring, whereas before it wouldn't have done that. Jowls coming down from the neck pulling it, jowls also happening from depression, jowls also happening from the face pulling down. All of that is resolved and looks smooth and soft because there's no excessive type of excision, hollowing, or excavation which occurs down over here, which keeps the neck looking soft. You can see improvements all the way down to the bottom of the neck, even though the dissection you saw stopped halfway down at the level of the superior point of the thyroid cartilage. And this, to me, is the most impressive result because you see how much the eyes improved. This is with no Botox. We're going to Botox her today. You can see how much the lower lid improved from that skin excess that we removed. And if you look at the lower lid, you'll see that the shape has not changed. We only got rid of the redundancy which occurred in the medial part of the eyelid
as you age in this direction, and we took it back out in that direction. So the lower eyelid, you can see the shape has not changed. If anything, it's mildly improved in its shape, and you can see that on both sides. No scar visible because we followed the natural contour, and the rhytids are fully normal. They are not exaggerated medially, and they are not exaggerated from doing a vertical skin pinch, which is a bad way to go. And you can see the improvements in the mouth. I've just brought it back to life all the way around. What improvements the nanofat made for the radiance of the skin in all those areas over there. But this, again, my favorite view, because you see what a witch's chin is. Most people don't know that. They don't understand that. Follows a small line all the way up to the buccal space, which is right there, anterior buccal space, follow down to the prejowl sulcus, and that goes down into the chin. So you can follow that from the side, and you'll see that's the anterior buccal. That's where it starts. Follows down to the prejowl sulcus, and then down into the witch's chin where you have your transverse mentalis muscle. So it's around the DAO. So here you can see how much improved that is, and again, the witch's chin from this side, how improved that is, and how the contracture is better, and how the position of the hyoid is higher. Hyoid should be high, right behind the mandible. All right, would you do this again?
Absolutely.
All right. Thankfully, we don't have to. Not for 10 years.
Yay!